Yes, I hope you all enjoyed the yesterday's program, especially the pre-dinner session. Thank you. Now, I would like to welcome you all on the second day of PanCon 2022. I, Dr. Subhash Subedi, intern doctor at Chitwan Medical College and Teaching Hospital, would like to welcome you all as a Master of Ceremony on the second day of 9th National Conference of Psychiatric Association of Nepal, PanCon 2022. The thematic area for today's session are Mental Health Survey, A Tale of Nepal and India, Family Institution and Mental Health, Neurographic Art Therapy, a avenue in the treatment of mind disturbances. Only movers and shakers are not seizures. How to write and publish in the scientific journals. Now, to begin with the first session of the day, we have a symposium ahead. The thematic area of the symposium is a Mental Health Survey, A Tale of Nepal and India. The presenter of the symposium is Dr. Bigya Shah and team. And to chair the symposium, we have with us Dr. Nirakar Manshrestha sir and Dr. Santosh Chaturvedi sir. Excuse me, sir. Now, I would like to hand over the floor to the chairs. Thank you.
Team, and I first call upon Dr. Bigya Shah to present. Okay, Dr. Ravi Shah. Okay.
And all the ladies and gentlemen present in this room, a very good morning. Today we are going to bring about a very interesting topic. We all know that when most of the researches comes from the high income countries and the low income countries, the contribution is less than 17%. Yesterday someone also told that. And we tend to extrapolate the existing data and try to extrapolate and apply in our sense. And today only also our chairperson, honorable chairperson, told us that that doesn't work. We have to establish our own. Not just that, even when close neighbor like India and Nepal also, there also should be differences. We should work hard to establish our own. So keeping in line with that, so we are trying to learn from each other and then also establish our own. So this is the tale of National Mental Health Survey of Nepal and India. We put this title inspired by a very famous novel, Tale of Two Cities. So this is a tale of two countries. So what we will be presenting in this symposium is, I'll be just introducing the aims and objective of our symposium, and then the crux will be dealt by my colleagues, Dr. Bigya and Dr. Pawan. The reason that we got interested, of course all Nepalese would be interested in data from India, but particularly we were interested because all three of us were trained in India and working in Nepal, so that is again an additional motivation for doing this topic. I think the August gathering knows that, and everybody I think those who are interested in mental health, we all understand the huge burden of mental illnesses, and then but this is not taken due care in countries like ours. It is very heartening to say that at least both of the countries have done national mental health surveys, although late, but it's done within this decade only. India has done the national mental health surveys in 2015-16, and then Nepal also could complete in 2019. So we are trying. This is, as I said, is that without epidemiological data, it's very difficult to plan ahead, and then country-wise prevalence of mental disorder is required for accurate estimation of the burden, as well as planning all the health resources and mobilizing. So that is very essential. So I don't need to highlight more. And then in the data that are available in the world, all the countries seem to have a different burden. Although there is similarity, but there are, if you look at carefully, there are variations also. But variations could be due to many reasons. It may be due to differences in the tools employed, or maybe the sampling methods, or the techniques, or even time duration. So we are also trying to find out if there are such differences or similarities between our two countries. So I think I will not bore with this. Most of the people know about it. So if we compare India and Nepal, the population-wise it's more than 80 times, and then similarly the geographical areas also it's more than 60 times of Nepal. Although it may sound small, our country is small, but again the data or the knowledge generated, I think that doesn't matter whether it is a small country or a big country. And then but we can easily say yesterday Dr. Shah, the president of this SARC Psychiatric Federation, was also saying that he hardly feels any difference when he is in Nepal or in India. So that tells a lot that we have so much of similarity in terms of culture, in terms of geographical proximity, and everything is there. And then we also tend to extrapolate the data from India. So if this is in India, then it must be in Nepal. So we tend to do that, but is it really so or not? So this is what we are trying to do that. So I have already said that it is recently done within this decade, 5-6 years span. This is done. So let me briefly talk about this National Mental Health Survey in India. Here we are very fortunate that the institute that laid the National Mental Health Survey in India, we have one of the chairperson. And similarly, regarding National Mental Health Survey of Nepal, we are glad to inform that two of the presenters, myself and Dr. Pawan, we are involved in the research. Myself as a member in a steering committee, and then Dr. Pawan as a technical committee, in a member in a technical committee. So, okay, about India, the population taken were around 35,000, and then it was done in 12 states, in 43 districts. In each state, around 3,000 people were collected, and then the response rate was around 91.1% and 78% at household and individual level. These were all door-to-door surveys. In Nepal, we have collected nearly half the amount of the total population, but there's a little difference is that we have included huge number of adolescents also. 13 to 17 years were almost 6,000, whereas in India it is less than 2,000. And then the response rate seemed to be better in Nepal, around 97%. I'll skip this, I have already talked about this. So the purpose of our symposium basically is to understand the differences, whether those methodologies were different or not, and so that we will understand more the common grounds to conduct national surveys in futures. We could learn from each other's strength and weakness, and then similarly, if there are chances, maybe we can have a more collaborative epidemiological and interventional programs related to mental health in the two neighboring countries. So with this, I would like to call upon my colleague Dr. Bigyaf to talk about the methodologies and then the results. So, thank you very much.
Good morning and namaste. Thank you, Dr. Ravi. Respected chairpersons and dear audience. Please bear with me for the next 15 to 20 minutes because I'll be describing you some facts and I'm sure you'll like it. So I have nothing to disclose. Although before doing that, let me explain to you how we plan to do this narrative review. We have reviewed published papers of national mental health surveys of both the countries till September 1st, 2022. And consensus was developed among the co-authors and we generated themes for comparison. And the themes were prevalence of mental disorders, treatment gap, service utilization, help seeking, barriers to care access, and disability and cost of illness. But we have excluded epilepsy on our results and discussion. And coming on to discuss what are the similarities and differences between the two surveys. We have divided it on the various topics as mentioned here. I'll be starting with the socio-demographic details. Well, as you can see, that majority of the adult participants in both of the countries belonged to the early adulthood, that is 18 to 29 years. Most of them were females, illiterate, housewives, married in both the countries. But National Mental Health Survey further, they have tried to assess the area of residence, and majority of the adult participants belonged to rural areas. However, such details of adolescent population has not been published in both surveys of both countries. Coming on to the adult population, when we look at the prevalence of various mental disorders, let's begin with the prevalence of mental disorder. Then we see that the prevalence in India is more than that of Nepal. The lifetime prevalence of mental disorder is 13.6 in India and 10.6 in current prevalence in India, whereas it's 10% as lifetime prevalence in Nepal, and the current prevalence was 4.3. Similarly, common mental disorders and severe mental disorders, these were further, the data was extrapolated and the findings were available, but we don't have the corresponding finding in our survey. If we look at the substance use, then according to National Mental Health Survey India, tobacco use disorder was the most prevalent, but this was excluded from our survey, that is in Nepal, and according to our survey, alcohol use disorder was the most prevalent, with lifetime prevalence being 4.2%. Coming on to other psychiatric disorders, the prevalence of schizophrenia and other psychotic disorder was less in Nepal compared to India. But if we look at mood disorders, then depressive disorders were more prevalent than bipolar affective disorders in both the countries. And if we see bipolar affective disorder as such, it is comparable in both the countries. Now going on to neurotic stress related disorders, well, it was comparable in both the countries, with current prevalence being roughly around 3% in both the countries. But if we see that of Nepal, then general anxiety disorder was the most prevalent among this category, followed by dissociative disorder. And in India, the most prevalent among neurotic and stress-related disorder was agoraphobia, followed by OCD, general anxiety disorder, social phobia, panic disorder with limited symptoms. But if we see panic disorder and general anxiety disorder, then these were more prevalent in Nepal compared to that of India. Coming on to other disorders, well, PTSD was the least common on this category in both the countries, and dissociative disorder and somatic symptom disorder was assessed in Nepal, with the current prevalence being 1% and 0.5% respectively. However, these were not assessed in the Indian survey. Further, in National Mental Health Survey India, when screened for intellectual disability, it was found to be 0.6% among the respondents, highest being in the age group of 18 to 29 years, and more relatively common in males and in urban metro, but this was not assessed in the Nepalese survey. And coming on to the suicide, well, the prevalence of suicidality was 5.1% in India, but please note that the Indian suicidality only includes the current prevalence, and it was 7.2% in Nepal, and the suicidality in our survey included current, lifetime, and future likelihood of suicide. And if we see the severity, then the moderate and high severity of suicide, the proportion was around half when compared to that of the Indian data. And suicide behavior disorder was further assessed in our survey, which had 0.9 prevalence. And when we further see other details of the Nepalese survey, then as visible here, 6.5% had current suicidal thoughts, 1.1% had lifetime suicide attempt, 0.3% had future likelihood of suicidal attempt, whereas Indian survey reported that around 3.5 had current suicidal ideation in past month. And if we see the correlations of prevalence of mental disorders of adults with socio-demographic variables, then the prevalence, lifetime as well as current prevalence of mental disorder was more common in the age group 40 to 49 in the Indian survey, and the same was that in Nepal. However, in the Indian survey, the substance use disorder was more prevalent in 50 to 59 age group, and psychotic disorder had bimodal distribution with peaks at 50 to 59 and second peak at above 60 years. And if we see the gender comparison, then it was more common in males when we look at the Indian survey. But if we analyze the lifetime and current values in Nepalese survey, then the lifetime was more in males, whereas the current prevalence was more among females in the Nepalese survey. Similarly, if we see the geographic distribution, then the lifetime prevalence of mental disorder was more common in province 1, whereas the current prevalence was more common in Bagmati province in Nepal. And according to the Indian survey, the burden of substance use disorder was high in rural areas, alcohol use disorder was high in non-metro areas, and the rest of the mental disorders, including suicide, was the most highest in the urban metro areas. And let's see at the adolescent data. The current prevalence of mental morbidity in India was 7.3%, which was higher than 5.2% as reported as current prevalence in Nepal. And if we see the gender, then it was comparable in both the countries among males and female children. And depressive disorder was more common than bipolar affective disorder in both the countries. And dysthymia was assessed in the Indian survey, whereas we didn't have this parameter in the Nepalese survey. Neurotic and stress-related disorders scored the highest in both the countries, where phobic anxiety disorder was the most common among this category, and phobic anxiety disorder and agoraphobia was the most common among the Indian survey among the adolescent group. And when we look further onto other categories, then in Nepalese survey, the second highest prevalence was seen among behavioral and emotional disorder. And if we see about the Indian survey, then intellectual disability and autism spectrum scored the highest among behavioral and emotional disorder, with the current prevalence being 1.7 and 1.6% respectively. And if we see about suicide in adolescent population, then the risk of suicide current, including moderate and high, was 1.3% in the Indian survey, whereas the suicidality, which included current as well as lifetime, was 1% according to the Nepalese survey. And Nepalese survey had such comprehensive results on suicidality, which was not there in the Indian survey. And if we further look on to other parameters, Chitwan gap, service utilization, help seeking, and barriers to access the care, then in the Indian survey, the mental health gap was 83% on the overall mental morbidity, where, as you can see in the chart, major depressive disorder was the most common, which had the highest treatment gap among common mental disorders. And if we see substance use disorder, then the treatment gap was 91.1%. With tobacco use disorder having 91.8, the highest among other substances in Indian survey. According to the Nepalese survey, about 22% of adults had sought treatment for any mental health problems in Nepal in past 1 year. And coming on to health seeking, schizophrenia and bipolar affective disorder had around 5.5 years median duration of illness, which was the highest among when compared with other disorders. Similarly, bipolar affective disorder had the highest median interval between onset of illness and consultation. And in average, 2 consultants were approached for treatment of mental disorders in the Indian survey. And schizophrenia and depressive disorder, the participants had mostly seen government doctors recently, and median duration of being treated on with consultant was highest among schizophrenia and bipolar affective disorder. And if we see about the pathways of receiving care, which was assessed in Nepalese survey, but then we didn't have that in the Indian survey, then it was found that 40% of the population, adult participants, actually spoke their symptoms to anyone, out of which they spoke mostly with spouses, other family members, friends and neighbors. And then comes health providers. So we were not the first options actually. And if we see for the other data, then 21.1% among the adult participants actually were adhered to the treatment prescribed by the service providers. And only 3.7% of the adults were admitted for the treatment. And if we see who they opt for getting treated, then psychiatrists don't belong to the first option again. It was non-doctors, it was doctors, non-specialists, and faith healers who were approached more than the psychiatrist on the first hand. And when barriers to access to care was evaluated, which was only done in the Nepalese survey, then there are various factors which led to the barriers, out of which being unsure where to go to get professional care scored the highest among the instrumental barriers. Similarly, wanting to solve the problem on their own, thinking the problem would get better by itself, and thinking that I did not have a problem. These 3 elements scored the highest among attitudinal barriers. Similarly, among the stigma-related barriers, it was their concern that what would family think, say, do or feel if they would come about the illness. This led them, and this was a great barrier for them to get the treatment and care from the mental health professionals. And coming on to disability, then we see that more than 50% of schizophrenia, bipolar affective disorder, depressive disorder, participants with such disorder actually had disability in various domains, work-life domains, social life domains, family life domains, and extreme disability was experienced in schizophrenia and psychotic disorder and bipolar affective disorder. And when we further look at certain domains, such as if they could do something, or if they could do nothing at all, then again these 3 disorders, such as schizophrenia, bipolar affective disorder, and depressive disorder, were the disorders where the individuals felt that they were severely affected. And coming on to the expenses, which was calculated in both the surveys, then the Nepalese survey not just shows the average treatment expense in past 12 months, but also other associated expenses, such as the transportation services, such as food accommodation expenses, and Indian survey, whereas it shows median monthly treatment expense for any category of mental disorder, which was more than 100 INR but Indian survey lacks this other associated expenses in their analysis. And if we, head-to-head compare the average treatment expenses in past 12 months and then reduce it to monthly expense and compare with the monthly treatment expense of Indian survey, then we can understand that the Indian population, they pay 164 Indian currency more than Nepalese population monthly. And the cost of illness when assessed, it shows that participants with alcohol use disorder, usually they spend more compared to other disorders. So this is what we have been able to assemble when we compared the two surveys, and this has been my references. Before concluding, I would like to acknowledge faculty from NIMHANS, Dr. Manjunath, Dr. Naveen Kumar, Professor Suresh, who have been guiding us throughout to write this review and for providing us opportunity to collaborate and then do the publication and then compare the data. Thank you so much.
Good morning, everybody. I'll be talking briefly about what are the differences and how the differences came, and more than the discussion I present, I would like the house to discuss more on that so that we can have further insight into that. So Nepal, I have been involved as a technical working member throughout the survey. So we had a steering committee of 10 people, of which Dr. Ravi, Dr. Sauraha, they were there. And then after that, we had a technical group of 23 individuals. In 23 individuals, we had Dr. Saban who is here, and there were people from NGOs, there were biostatisticians, there were nursing staffs, and then people from ministry, and and this was one group, and the other group was a tool translation team of 5 people. So who translated the mini tool of in English to Nepali. And then below that there were 6 field supervisors and 30 field data collectors. And the NHRC central team members, 9 members from NHRC were constantly involved throughout the survey. So they were mainly responsible for monitoring, and they were responsible for management and logistic part. So first of all, we trained for 3 days. The training of trainers, mainly the technical working group people were trained for 3 days in the initiative of Ministry of Health and WHO, and it was facilitated by Professor Dr. David Vincent Sian. He is the copyright holder of Mini Tool, and he came to Nepal and he trained us. And the most interesting part here was we requested him for free tool application, to which he told yes. So it was a very sigh of relief for all of us, because it would cost a fortune if we had to buy that. And then after that, a 21-day training was given to the data collectors and field supervisors by us, and this was facilitated by a psychiatrist, there were psychologists, and the researchers from various organizations. And for the minimum qualification, we had kept enumerators as bachelor's degree, either public health or nursing background, and supervisors should have a master's degree in public health. And for training, we did some presentations, we had discussion, we had demonstration, and we also trained the data enumerators and supervisors in clinical setting, that Teaching Hospital, Rhythm Hospital, Parna Hospital, and KMC, Kathmandu Medical College. These were the 4 sites where they were trained for 3 days there. So as Bika and Dr. Ravi have already presented on these things, so I'll just summarize the population, the data sample size, and the response rate was a little better in Nepal. So for tobacco use, it was discussed, we did a pilot survey. Before that, it was discussed that for tobacco use, we had a step survey in Nepal. So the researchers from NHRC felt that why to duplicate the same data? So it was not assessed. And for intellectual disability, autism spectrum disorder, dissociative disorder, there were additional questionnaire in India, but not in Nepal. And for dissociative disorder, we had additional questionnaire in Nepal. And for barrier to assessing care, the qualitative inquiry like focus group discussion and key informant technique was used in India, whereas for Nepal, we used BASE tool, that is the barriers to assessing care and evaluation. And for pathways to care, they were for the questionnaires and treatment gap. In India, the treatment gap was seen, but in Nepal, treatment sought, treatment offered and sought. That is the two. I think it would make similar impact. And then for disability, SEANS disability scale was used in India, and Nepal we had additional questionnaire for that. So to discuss a few important differences was the timeline that we did in 1920, and it was done in 1516 in India. And mini version was different in two surveys. The mini 6.0.0 was used in India, whereas mini version 7.0.2 was used in Nepal. So this mini version 7.0.2 had a little bit more on suicidality, suicide use disorder, those kind of things were there. So the larger pool of data was collected here. And translation of study questionnaire in Nepal was done only in Nepali language, whereas the local languages were used in India. And handheld electronic devices were used in India versus paper and pencil tool in Nepal. So fewer errors in data entry and data transfer would occur in handheld electronic device, and it would be less expensive to collect the data. It is said that way. And this has been already discussed about monthly expenditure and treatment sought and treatment received in India and Nepal. So there were some limitations in both the surveys. The exclusion of homeless, institutionalized people, prisoners and children below 13 years would be one limitation, and stigma might have caused underreporting of the cases in both the surveys. As we know that this part of the world has stigma regarding mental illnesses, and it's important to note that all states were not included, and I am at the National Mental Health Survey of India, whereas Nepal and India. And another important thing to consider here, as Dr. Santosh we had a brief discussion before, that as we say that Nepal and India are culturally or linguistically or say heritage-wise were very close and very nearby, but Nepalese context and Indian context could be different in many ways. So we should have our own experience. We should have our own experience. We should have our own data. So these differences in culture, economy, opportunity, resilience might have led to some differences in the finding of these two countries. And the most discussed thing after the mental health survey has been this in Nepal. So in province 2, that we call Madhya Pradesh, so the lifetime prevalence was 2.1% and current prevalence was 1.5%. So there was a great discrepancy between the findings of 5 other 6 provinces and this province number 2. So we had a lot of discussions there, and somebody thought that the data collected was not right, but we ourselves were involved in survey, and we ourselves had tried to maintain all the ethics and all the methodological part. So we thought that once the research is done, we cannot replicate it again, or we cannot do it again for the sake of getting a better result. So we tried to discuss in this matter, and we found some points to discuss on this. So it could be a real prevalence that Pradesh 2 or Madhya Pradesh has a less number of mental health patients. But due to resilience, it could be one fact. And other fact could be that language barrier, because in this part of the country, there are languages like Bhojpuri, languages like Maithili that have been spoken in the household. But we only collected the data in Nepali language. And the cultural sensitivity of the tool, the idiom of distress could be different in this part of the country, and stigma would be more in this part of the country, so it might have resulted in underreporting of the cases. And ethic and imic, so there are transcultural things or the culture-specific things, idioms of distress, so this might have contributed to underreporting. So, and then there are some things to discuss about the survey itself. The survey, we do a lot of survey, but it's not a final diagnosis, or it's not the actual prevalence, it's not the gold standard. Because the gold standard is history and mental state examination, and if we check the reliability, maybe 2 or 3 psychiatrists can see a single person and decide the diagnosis. And then it's a more of a screening rather than a diagnosis when we use a lot of patients, a lot of tools, and and do a survey. And it becomes subjective at times due to limited trend data enumerators. So we as a psychiatrist Even me, I've been trained for 10 years. Then there are some times that we do not get a right diagnosis. So it's very difficult to say that the data enumerators who are trained for 21 days to make a right diagnosis or to use the tool properly. And then the reporting by the participants would be socially desirable. When somebody comes to home and starts taking data, so people might be more desire to give a socially right responses. And the willingness to give a response also depends on the rapport of the enumerators. So these are the inherent problems or limitations of a survey. So with this slide, I'd like to have a discussion among us on the 2 mental health surveys of this part of the world. Thank you.
Sarvan, for the very nice presentations. And now the floor is open for any queries or any comments.
Firstly, thank you for a very, very nice and comprehensive presentation. So I was also a part of all these that was happening around. So a couple of interesting observations when I was doing the MMAP workshop with the UNICEF headquarters. One thing that came out, especially in regards to the child and adolescent survey, and Pawan, I think, there is also concern of overdiagnosis in Province 1. The prevalence of any mental disorder is around 13% for that province, and for every province other than Province 2, it's around 5 and 6%. For Province 2, it's 1%. So, on an honest note, I think there has been open discussions even among ourselves in the quality compromise in Province 2. And we say that because if all the reasons that you mentioned were applicable to Province 2, why would Province 6 have a response that is comparable to other provinces? Because Province 6 is so similar to Province 2 with the language barrier and all the epidemic approaches that you talked about. So I think in regards to where we went wrong or maybe where we can improvise in a follow-up survey is to think about better methodological strategies from an implementation perspective. So for example, for the Indian National Mental Health Survey, I think the team was larger as expected, and the training, I think, went on for 8 weeks, if I'm right. Our training was 3 weeks, and I think, again, there was no structured schedule. Vika was there for the training, I was there for the training, and we were training in a way, a group of people who didn't have the basic etiquette of, so they were basically enumerators. But I've used Mini in my PhD, and Mini is so intense. There is a lot of subjective component in a Mini interview that goes on. So in that respect, these are the challenges I think that has to come up. But I think sometimes any data is good than no data, but sometimes no data is good than bad data. So I think we have to have a mixed approach. So I think we did a great job with the mental health survey. We have something to talk about. There will be questions, but I think with papers like this, we'll have unified answers to all the criticisms, and I want to congratulate the team for that. Thank you.
Yeah, if I can, first of all, to give a background of National Mental Health Survey in India, from 2009 to 19 was probably the best period for mental health in India, because we had very good support from the secretaries and the ministry and all. And I was head of the department from 2007 to 11, and every day we would get questions from the parliament that what is the prevalence of this thing. And we have to, because we would give studies, the studies were done in 60s and 70s and 80s. If you can't tell from experience, I think it is increasing. Everyone wants data. In parliament they want data. So we said there is no data. They said there is some press report that depression is increasing, so we have to say there is no data. So then they said you do a national mental health survey. So that is one good thing. As Sagun said, we have data now. You can repeat it after 10 years. India, we are already starting the second phase of the national mental health survey, because in the first one we did only 12 states. So now we are going to include other states, and I think you have used a different version of Mini, because our data is incomplete, because it does not have the commonest psychiatric disorder. It does not include somatoform disorder. So actually, I would say mental health in Nepal is good. I would like to come and stay here. Now the thing is, one methodological problem. you cannot compare data from India with data of Nepal. Why? I will tell you. Out of the 12 states, often I didn't know I was going to chair and I didn't see the National Mental Health Survey now, but I know in Kerala, the morbidity is the highest, okay? And the suicide risk is also highest. Similarly, in some of the other states, other rates are higher. So there is no point comparing Nepal with Kerala. So what you should do is, state-wise data is there in the book. So you should compare Nepal with Uttar Pradesh, Uttarakhand and Northeast. Because these are the things which are close to Nepal and they have more traditional, cultural, commonalities as compared to Karnataka or Kerala or Tamil Nadu, which is very different. So what happens is when you take all India data, then you get an average. So that is not right. As you see in your own country, there is difference between provinces, and that is one point. So I think you have to reanalyze the data. You should not look at India data, look at state data. The second thing is about suicide, and again, dissociative disorders. You have it, we have not studied also. And that is a common phenomenon, both somatoform and... So we asked her, and it was one of the things which we were taking. I'm one of the, advisors, if you see in acknowledgements, my name is there. But they found it difficult to assess somatoform and dissociation. So that was one of the reasons, because there was a pressure of time. So they wanted to do things which could be done much more rapidly. So coming to the issue of difference between province 1 and province 2, I don't know why you should suspect, because if you have used the same scale, same training, same everything, the same things apply to everyone. I mean, how can you say that, this was less reliable, there was more reliable? It doesn't happen. If you recall, the WHO IPSS study, International Study for Pilot Study for Schizophrenia, and the 1-year outcome, 5-year outcome, 10-year outcome. Outcome was better in developing countries as compared to developed countries. And nobody in the West believed it. So they did a 2-year follow-up. And then they still found it is better. They did a 5-year follow-up. They still found it is better. They did a 10-year follow-up and they still found it better. Now, you have used the same scales, then people started saying maybe it was not administered properly. What do you mean not administered properly? The same scales are there, there's structured instruments. Then, so there is a group of people which was opposed to that, because they could not take it, even with a pinch of salt, that countries where psychiatrists are less and facilities are less has a better outcome of schizophrenia than countries which have more. Then they started talking about various things like family, joint family, tradition, support from family, various psychosocial factors. So this is a good study. Somebody should take it up for PhD now. You have got many PhDs here, and Rishabh is there, and others are there who can, guide and see why do a qualitative study. What is the difference between province 1 and province 2? There must be something, It can be differences in what they eat, it can be differences in their traditions, it can be differences in something or the other, but it is a marked difference, it's not a little difference. So accept it, and maybe that is how mental health varies from country to country. I am not sure. There was a WPA mental health survey done in the early part of 2000, based on which the ICD-11 was made. I'm not sure whether Nepal was a part of it or not. So you have to look up, it is in World Psychiatry Journal, it's a freely accessible journal, and you just put World Mental Health Survey. So India was a part of it, and you find many countries, I think almost more than about 100 countries were participated in that. So if you have figures of Nepal prevalence in that, then you can compare that with this. So, but otherwise, I think it's very good, because this is what is required for policymakers. They would like to know the prevalence, they would like to know what services can be prepared, treatment gap. See, another thing which we don't consider in treatment gap, why I think it is not an accurate thing is that because treatment gap is with allopathic treatment. Okay, but we know that in north of India and even south of India, there are a lot of mild, moderate mental health disorders are seen by various other, like you saw the pathway of care. We have shown there are various other methods. So there are Ayush. Ayush is a full ministry now in India, and there must be in Nepal also. So Ayurveda, Unani, Siddha, Yoga, and naturopathy. There are so many things. A lot of people go there. And the response to mild to moderate mental health problems are much better in that. Allopathy is a handful of drugs, so antidepressant, antipsychotic, benzodiazepine, and mood stabilizer, that's all. There's nothing, there's not much, but in the others which are more holistic, which are more related to, the development of mind and other things. So the treatment gap, when you calculate, you should also take into consideration that, and then you will find the treatment gap is actually much less. So I don't know whether you are aware or not, she called the Queen, the wife of the King of England, Pamela, she has just been to Bangalore for 2 weeks for a holistic treatment which is not available in UK. And it was obviously naturopathy and meditation and yoga, and then she's gone back day before yesterday. So it is there, people know it is there. So it is not considered as formal treatment. There is stigma against traditional treatment, which is very sad, but they are there. So, but I would like to congratulate you all for having looked at it, but you should re-look at the data. This is not correct. If you will send it for, I don't know, it's published already? If you send it for publication, they will say, how can you compare? A huge country with a huge this thing with a small this thing, so you should do it with a much more. Maybe compare first, do it 2 steps. Compare the demographics of Uttar Pradesh, Uttarakhand with Nepal, and whichever is closer. Otherwise, you just do the neighboring states. I can see, visually that probably Nepal is closer to Uttarakhand, maybe North Uttar Pradesh and Northeast. So if you compare those 3 states and Nepal, and then you see what is the difference. There's no point comparing with Kerala and thank you.
Any more question? Okay, I will say anybody. I think you can sit down. Comparison between India and Nepal. And you have brought out the differences between in the prevalence rate, disease-wise also, age-wise, sex-wise, treatment seeking-wise also, treatment expenses-wise also you have brought out. And as Dr. Santosh has rightly pointed out, there is no point comparing, the 2 countries. Because even in India, the interstate differences are there. The Punjab and the Uttar Pradesh, almost double. So, and there are many factors which are responsible. The most important factors, I think, the social problem factors, the economy, the stigma, attachment illness, the language barrier, and also most important is methodology, which tools we have been using. And I have conducted survey, NCD started survey, WHO step 2 and I'm a principal investigator, as a national survey. Even because of the enumerators, the level of the enumerators and how they talk, that also makes a difference. And also the timing of the survey, that is also very important. And the most important factor is the motivation of the sample, the subjects. Whether they are motivated to take part in the program or not, in the survey. If they are not, then they will respond sincerely. So all these factors, I think, are responsible for the differences. And as Dr. Santosh has rightly pointed out, we have to do the survey again and again. And in the same sample size also, if you do the study of 4 years or 10 years, you find the differences. Not only because of time, because of many other factors also. So with this thing, I think it is also 9:45. I thank all the three presenters, Dr. Ravi Sakhi, Dr. B.K. Shah and Dr. Pavan Sharma. And I especially thank Dr. Santosh for highlighting the important points in the survey. And I thank everybody who took part very actively in this discussion and giving comments. Thank you very much.
Respected Professor Dr. Nirakar Manshrestha sir and Dr. S.K. Chaturbedi sir for chairing this session. Now, for the felicitation of these respected speakers and chairperson, I would like to request Professor Dr. C.P. Serai sir to kindly come forward to present the token of love. Thank you. Similarly, I humbly request Dr. B.K. Shah to kindly come forward to receive the token of love. Thank you. I would like to request Dr. Pavan Sharma sir to kindly come forward to receive the token of love. Thank you. Now I would like to request Professor Dr. Nirakar Manshrestha sir to kindly come forward to receive the token of love. CP sir. Thank you. I humbly request the chairperson of the session, Dr. S.K. Chaturbedi sir, to kindly come forward to receive the token.
I was only proxy.
So please.
But the contribution was most valuable, sir.
Thank you. Thank you, Professor Dr. C.P. sir, for the felicitation. We are now moving on to the next session. Family institution and mental health. And to present on this topic, I would like to call on stage respected Professor Dr. Indira Sharma ma'am. Professor Dr. Indira Sharma ma'am is the Professor Emeritus at National Academy of Medical Sciences, India. And to chair the session, here we have with us Professor Dr. Are Holland. Dr. Are Holland is the Professor Emeritus at Norwegian University of Health Sciences. I would like to request Professor Dr. Are Holland to kindly take a seat of honor as a chairperson, and I would like to hand over the floor to the Professor Dr. Are Holland. Thank you.
So, welcome to Professor Indira Sharma, going to talk about family institution and mental health. We look forward to hear your presentation. Thank you.
Yeah, okay, that's better. Okay, good morning. Today I shall be talking on family, institutional and mental health. I will request the people at the back to come sit in front, if it's not very inconvenient. This is the family. Now, what is a family? A family is a group of two or more persons related by birth, marriage or adoption who live together. It is a basic unit of society, and we have many types of families: the nuclear family, the joint family, the extended families, which there may be vertical extension and there could be horizontal extension. And these members of the family, they generally live under the same roof. Sometimes they may be living separately, but still they maintain jointness in various ways. Family is the dominant institution in the life of people in India. Now, what is the origin of a family? The origin of a family is procreation. And marriage is the social institution by which the family is generated. If you look at the Shastras, very clearly mentioned, man is only said to be complete after marrying a woman and acquiring progeny. The Shastras also mention that everyone must marry. To be mothers were women born, and to be fathers men. Childbearing and child rearing have been primary roles of women in India. Now, what are the functions of the family? We all know the functions. They meet the basic needs. As we say, roti, kapda, makan, food, shelter and clothing, health, education. They help you to get an employment, provide support within and outside. And they also make sure that the children, they make all efforts to get the children married, take responsibility, they provide security, other needs. And to summarize, one can say that family provides comprehensive care to all the members. And it has inbuilt mechanisms to take care. For example, in the absence of the parent, the elder brother becomes the father, the elder sister becomes the sister. Or if the chacha is there, chacha is the father's brother, or the cow, the elder brother or younger brother, then they assume the role of the father. So this way, everyone is taken care of. Even in the absence of the parents, others assume the responsibility. And to summarize, one can say family promotes mental health. Now, when we look in the setting of mental illness, how do we use the family? In general, one can say that family is the key resource, the primary caregiver. And this is because the family values are very strong and they care for the near and dear ones, both in the happy days and the sad days. And they prefer to be involved in the care of the patients. I remember in the Banaras Hindu University, the families were there making food outside, and sometimes it would rain. And when the chancellor of the university came and saw the critical condition, he immediately said, why don't you make arrangements for these families, they can cook. So you see, the commitment of the family, they suffer and still they are with the patient. And so then they the rooms were made so that they could make the food there and supply it to the patient. Then the other thing in India is, in developing countries, the paucity of trained staff. And families also, they compensate for the trained staff, and clinicians to a great extent depend on the family members. And thus, seeing the scenario in India, and I think also in Nepal, adequate family support is the need of the patient, the clinician and also the health administrators. If they do not make arrangements for involving the families, then it will be difficult to manage many of these patients. Now, how do the families help? In general, one can say they detect the illness, they find something abnormal, they come to the doctor, they bring the patient to the doctor, they provide detailed history, provide all the OPD treatment and get the patient admitted when need be, and provide all the help, take care of the patient after discharge and bring the patient for follow-up, and also they have a major role to play in the rehabilitation of patients. Now this was in general, but I would just like to mention here Dr. Vidyasagar, who is considered to be the father of psychiatry in India. He set a good example. He was the superintendent of the Amritsar Mental Hospital, and he allowed patients, he involved the family members in the treatment of patients, and allowed them to stay with their patients in open tents pitched in the hospital campus. This was very, very unusual, but the results were remarkable. Thereafter came the family wards in Vellore, and the results were again very good, and there was fast recovery and low relapse rates. Then let us look at some of the more specific references with regard to family. Now Sethi in Lucknow, he described the unique abilities of the family which can be exploited therapeutically in the treatment of mental ill. Now then there have been surveys of mental hospitals and have shown that large number of long stay patients have practically no contact with the family, and this was considered to be very unhealthy. And I must put here on record the efforts of Dr. S.D. Sharma, the director of Hibas. When he took charge of the hospital, he used the Mental Health Care Act 1986 to make sure that the family contacts the patients. And in the Mental Health Act there is a provision that if you come to know that there is a patient who is a psychiatric patient is not receiving treatment, then the complaint can be made to the DM. The DM will impose a fine of 2,000 rupees and will give an order to the relative to go and get the patient treated in the hospital. So with this law, almost 80% of the patients could be brought to the hospital, the relatives could be brought to the hospital and contact could be established, and many of them could be discharged. The initial problem was that when the families were told you come, they were very apprehensive of taking the patient back. So Professor Sharma, he made available 24-hour emergency for the family members. Whenever you come at any time, you have a problem, we are here at your service. So that itself was a great thing, and because of this, many patients could be sent back to their homes. Then in the 1960s to 70s, we had a general health psychiatric units and the private psychiatric homes. And in these, the family involved in the care of psychiatric patients. Then the community mental health program, the National Mental Health Program 1982 in India, it insisted on treatment should be given where the patient is, where the problems arise, and this focused again on the family. And the WHO report 1974 also focused on the family. Then it's not only India, but if you look overseas also, they recognize the importance of the family. And the APA guidelines recommend the involvement of the family in schizophrenia. It clearly says that patients and their family members who have ongoing contact with each other should be offered a family intervention, such as education about illness, crisis intervention, emotional support, and training how to cope with illness symptoms and related problems. In bipolar also disorder and major depression, the APA recommends early family involvement. So then looking at the, I just want to tell you that overseas they were very much surprised that what is the reason why India the progress is so good. So international study was carried out on family interventions at NIMANS. And the results are very gratifying. And there are a number of studies from which have reported the positive effect of family interventions. Then let us look some of the evidence. Traditional joint families mediate the role, mediate the good course and outcome of major mental disorders. This has been said by Leff. Then nuclear family structure is more likely to be associated with psychiatric disorders than joint family. Again, emphasizing that it is a bigger family which is important. Then the patient in the rural areas, they sought, fewer patients sought hospitalizations compared to those from the urban areas. So again, the rural environment is better. And then the larger families with better educational status tended to discontinue attending a day hospital facility within 3 months. Again, all these provide evidence of the positive role of family in the management of psychiatric patients. Then the 3 large international collaborative studies also provide evidence on the positive role of good family support. And they are the International Pilot Study of Schizophrenia, the determinants of outcome of severe disorders, the international study of schizophrenia. Persons with schizophrenia did better in India and other developing countries compared to Western counterparts. So these results are again very gratifying. Then there are two cross-cultural studies. They have reported that it is less than 50% of patients live with their families in the Western world, whereas 98.3 patients lived with their families in India. So again, India is definitely better, and this is the strength of the Indian culture. Now, there's a lot of scientific evidence to show most significant contribution in family interventions are the most significant contribution to psychiatric practice, and we know now the positive results of family intervention in schizophrenia, bipolar disorder, major depression, borderline personality disorder, and alcoholism. They reduce the rates of relapse and improve quality of life. Then family education in 11 studies again was found to be helpful compared to the control group. And then in major depression, inclusion of a family therapy component led to greater improvement in patients with depression and suicide ideation than treatment without the family therapy. Then in other diagnostic categories also, agoraphobia and panic symptoms, partner-assisted cognitive behavioral exposure therapy provided on an individual or group basis led to clinically significant improvement in 54 to 86% of the cases. And then also in obsessive compulsive disorder, family-based approaches have been found to be more effective. Then there is a 10-year follow-up study conducted of first episode schizophrenics in India, and it found that early therapeutic family interventions they helped in stabilizing both the positive and negative symptoms of schizophrenia in the first 2 years of illness. And so you can see there is a host of evidence to show that involvement of the family is very good for the treatment of patients with mental illness. And I would say it is far better than without having the family, and it has least stigma. But giving you this background, let us see what is the changing scenario. The changing scenario is, first is the nuclearization of families. And this is evident from the reports in 1981 census, 1991 and 2001 census. Whereas in the 1981 census, the population growth was greater than the growth rate of households. In 91, it was the other way around. The number of households grew at a fast pace than the population. And this trend was further magnified in 2001, with these trends are clearly available in this table which is before you. Then the other problem is not just that the families are becoming smaller, nuclear. The other problem is the functional decline, even though there are 4 or 6 siblings. But the problem that we are witnessing in the modern era is that children don't want to live with their parents. Many of them live out to work, many of them don't like their homes, and many of them live out to prepare for competitions. And it is very surprising. I came across a few cases in clinical practice where the children don't like their homes. It is very surprising. And during the COVID, they prefer to stay and go at the beach rather than in their homes, the brother and sister. And the parents were helpless because they were earning, they had no control over them. Then I had 2 young ladies, they were living out, not in their homes, because they didn't like their home. Then another problem that we are witnessing in our country is everybody wants a government job, because in a government job, it is perceived that there is a very good salary, very little work, and there is so much of democracy that nobody can remove you from the job. So people spend years and years and years preparing for competitions, and they don't stay at home. They stay in some big city like Delhi or Lucknow. So functionally you see the family size becomes smaller. Their parents are sending their children for higher education, tuitions, and to live with distant relatives and even in hostels. Their priority is education. Their priority is neither security of the woman, neither marriage. Its priority is only higher education. And parents are filthy rich. Then, so after talking about the size of the family, the real size and the functional decline, the other problem is the abortions. Now, before 1971, the abortion was criminalized under Section 312 of the IPC, and describing it as intentionally causing miscarriage, and the provider would get 3 years imprisonment and/or fine, and the woman 7 years imprisonment and/or fine. However, in 1966, abortion was made legal in 15 countries, and then in India there was the Shanti Lal Shah Committee, which was asked to give some suggestions, and then came the MTP Act 1971 and the amendments in 2002 and 2021. What is more disturbing is that the judiciary has become very, very liberal in allowing MTP abortions. It is allowing both for married, unmarried, living relationships, rape survivors, and change in marital status, recently widowed, recently failure of contraception, and even in advanced pregnancy with negative medical reports. So this case is from Uttarakhand, where the 16-year-old rape survivor was allowed to terminate a 28-week-old fetus despite a negative medical report. The court took the pretext that no use living without dignity. The only way is to allow come what may, despite the negative report. So this is the state of affairs as far as the MTP Act, and because of this, we are having a lot of abortions. And but to my mind, the MTP Act needs more attention and it needs to be amended. Then subsequently there came the law in the Supreme Court on 25th June 2022. The decision was made by 6 versus 3 judges. The bench, they overturned the Rose and Wade in 1973, which has been the basis for legal abortions across America for nearly half a century. And the court took the plea that the right of privacy of a woman must be considered against important state interests in regulation. In the same line, recently I just went through and found that in India a PIL has been made against the reproductive rights of the woman under Article 21, and this has been admitted in the court. Now, what is more disturbing regarding the abortion law? Number one is that I find this to be a triple exploitation of the woman. First, the man impregnates her, then he refuses to marry her, and then he says, go and get it aborted, and so she has to face the risk also, because many may die also. So every surgery is a risk to life. So it's a triple exploitation of the woman. And they have made it so cleverly, as if they are helping the woman to do it. Actually, it is a terrible exploitation of the woman. This is the way I understand. And the other problem with these abortion law is, what about the rights of the father? There are no rights of the father. How can this be? How can a woman get the child aborted? What are the father's rights? So this is again the major lacuna in the abortion laws. Then if you look at the WHO report, it says that 6 out of 10 unintended pregnancies ended in induced abortion, and 45% were unsafe, and 95% of the unsafe abortions take place in developing countries like India. Another interesting study, which is from KEM Hospital, Mumbai, it showed that if you compare the situation from 72 to 78, whereas in 1971 the ratio between delivery and MTP was 10:1, in 78 it became 2.92:1, which means that the number of abortions are now increasing and it is almost becoming equal to that of the delivery. So this is a very sad and dismal state of affairs. Now let us look at the, having talked about the abortions, the third issue is the infertility rates in India. The general fertility rate, which is the children born per 1,000 women in the reproductive period, has declined 20% over the past decade. And this is a 3-year period, 10 years before and now. This is 2008 to 2010 versus 2018 to 2020. And the decline has been more in the rural than the urban areas. Then the total fertility rate, that means the number of births by a woman in reproductive age, the national rate is 2.1. The highest is in rural areas as compared to the urban areas, and the highest was reported in Assam and the least in countries like Delhi, Tamil Nadu and West Bengal. So you can see these are very alarming figures, which means a person would have not more than 2 children on an average, 2.1. Then what about the male fertility? Male fertility rates are also declining below the age of 30, which is again a cause of concern. And the other issue which I have always been worried about is that infertility rates have been rising, and this has led to increased demands for IVF and surrogacy. To my mind, this is a highly unethical provision. For these IVF and surrogacy laws, the rich exploit the poor. It is unimaginable that a woman who keeps the baby in the womb for 9 months gives away to somebody else. So this is highly unethical. It should be stopped. Then what are the causes of the decrease in the fertility rates? The causes are very clear. There are social causes and there are medical causes. The social causes are late marriage and aspiration for a government job. So because a person doesn't get a job, neither the boys and not even the women also don't want to get married. And the parents don't think about marriage, they want also the woman to be employed. So this is one of the reasons for late marriages, higher education, then attitude of women and family, gender equality and women empowerment. So now women want to work like men, be equal to men, and the parents also support. Partly because everybody likes money, it's a rich man's world, and also because there are so many laws to protect the woman. And in fact, it is under domestic violence that you prevent a woman from working. So this is another problem that we are seeing. Then women are not interested in becoming pregnant, they think it's a burden. And then married but not living together. This is a very common scenario. I remember in our times, if the husband was elsewhere, the lady would resign from a job and live with the husband. But now this does not occur. They are living together and working. And because of all these reasons, women living in hostels, other places, sex out of marriage has become very common, leading to abortions. Then rapes are also very common. And then, just to mention here, mobile use. People are in the habit of keeping mobile in pocket. This itself reduces the sperm count and the quality of sperms. And it also affects the fertility of women. So I think we need to attend to this. And of course, there are medical causes. We all know that PCOS, polycystic ovary in women, obesity, and in men, history of mumps, and diabetes, mellitus. These are some of the common medical causes of infertility. Now, what are the take-home messages? Having elaborated upon the importance of the family I would like to mention here the first take-home message is that everyone must marry. This is God's arrangement. And it is not enough to marry, the marriage should be at the right time. In India, the marriage age for women has been raised from 18 to 21. So to our mind, the marriage should be between 21 to 25 years. And because the first baby should be before the age of 30. Otherwise, the chances of congenital anomalies increase. The other thing is that marriage means living together. This must be adhered to. Then marriage without children is incomplete. Then the ideal size of a family, what should be the ideal size? It should be 4 to 6. Every sibling should have an elder sister, elder brother. A younger sister, younger brother. That would be the ideal, although this is not being met, but ideal would be 4 to 6. When I was in Malaysia, most families had at least 4 to 6 children, and they managed them well. Then preserve the family. Family treatment is natural and has least stigma. Then a woman should be proud to become pregnant and mothers. The other message we need to give is work and family are compatible. People think they are not compatible, they are compatible. And the society and the state should support working women. Then all steps should be taken to prevent unwanted pregnancies. And if in case it does occur, the unwanted pregnancy, then the route should not be abortion. It should be, these pregnancies should be given for adoption. This baby should be given for adoption. Then what about the safe rape survivors? Another problem with the rape survivors is, again, the baby should be given for adoption. Already there is a trend, the Supreme Court is considering that they should be given for adoption. So why not make a law? Because in the Hindus, sex out of it, all religious sex out of marriage is not permitted. So whether it has been by consent or without consent, if the sex has occurred and they have been impregnated, then it should be treated as akin to marriage. If the man is very nasty, he should be immediately divorced on the ground of cruelty, and he should be made to pay the woman alimony. So some sort of a law should come up for that. This is the way I think. And once she has a marital status, there will be less stigma for her to go in future. And she may keep the baby or she may like to give it for adoption. That may be her choice. This is the way I suggest. And then there is a need to make amendments in the Mental Health Medical Termination of Pregnancy Act. And the legislation for adoption needs to be liberalized. After saying all this, I would just like to quote, family is not an important thing, it is everything. Family is the most important thing in the world. Princess Diana. And then a family is but an earlier heaven. George Bernard Shaw. Thank you very much for your patient hearing.
Thank you very much for this scholarly review of the importance of the family and the positive, showing us the positive and underlining the positive aspects of family dynamics in relationship to not just schizophrenia but to many mental disorders. Also, I think it is interesting to compare the Western context of the family with the Eastern concept of the family, as that shows some of the differences of what is happening with a higher speed in the West than in the Eastern part of the globe. Also, your worrying aspects of what makes the family be less of an institution to the extent that it has been, male infertility as well as abortion, late marriage due to job and higher education, and the decline of the nuclear family. All these aspects are things that can be discussed. There are many different views on these issues, but thank you for reviewing it all. So the floor is open to questions, comments for those who want to use the opportunity. Yes.
Thank you, Dr. Indira Sharma. It was a very nice and very comprehensive presentation, and I agree with you. And everything that you said in a lecture, that applies to in the context of Nepal also. And I have been practicing psychiatry for the last 40 years. And I see at least 40 to 50 patients a day. And to a surprise, I hardly had any patient. I all treat at their home with the support. And as you said, if you explain about the disease, about the treatment plan, you sit together with the patient and the family members and make the treatment plan, how long the treatment will go, what is the medicine the patient has to take. Sometimes the patient is psychotic, no insight, they don't want to take medicine like manic patient. How to give medicines? I usually give olanzapine dissolved in water. In olanzapine, they will sediment, but in some company it is very good. So they will give it like that, or 4 or 5 days time, the excitement is decreased, the aggression is decreased, patient becomes comfortable, and patient also becomes cooperative, and patient eventually start taking medicines. So the family has a very important role, especially in the treatment of mental patients. That is my own experience. Now regarding the decrease in total fatality rate, you said few points. You have talked about the mobile also. Saying that mobile, has some effects, some electronic or something like that, or just because they are busy in mobile and so the husband and wife, they will not, have a relationship. So what do you want to say about the mobile, use of mobile? In the decrease in the total fatality rate, you have rate in mobile use. So my question is, how does it affect the total fatality rate?
Question is not clear, I can't hear it properly.
The total fatality rate is on the decline in India. It is also in Nepal. Okay. And in the comparison of total fatality rate, decrease in the total fatality rate, we have created mobile use also. How does that affect mobile use in the total fatality rate?
You are talking marital rate.
Total fatality rate.
Yeah, the marital rate is actually in India there has been a lot of debate on marital rate, how it should be dealt with by the judiciary. Okay. And the pressure on the judiciary is so much that after a lot, it even asks people to be seditious, right? People. And then finally the Supreme Court has given way and allowed the lady to file a criminal case against the husband. But the Indian Psychiatric Society, and when I was a president, I have suggested to the government that domestic violence, which includes marital rape, sexual abuse is marital rape, should not be dealt by the criminal law. Because if you deal by the criminal law, then you will ruin the marriage. The husband will never forgive the woman who has filed a criminal case against him. So you should be dealt for civil law, and the best law for it is Protection of Women from Domestic Violence Act. And the other thing is, marital rape, the main cause is often a psychiatric disorder. I'm sure you must be knowing of the famous Bobbitt case in US. Where the man used to take alcohol, repeatedly he would rape his wife, and one day she got so furious that she took took a knife from the kitchen and cut his private part. But immediately she understood that probably I had done a blunder, how should I do it? So she had thrown it out of the window, but she went and searched and could find it. And she took the husband in a car to the surgeon and got it reunited. So the judiciary does not understand that marital rape, the cause is usually it is a psychiatric problem. So psychiatric assessments must be included in the code of procedure, and there must be an assessment, and the treatment is psychiatric treatment and not penal measures as in the IPC. This is what I am saying.
Thank you, ma'am. Ma'am, actually, sir wanted to ask that you talked about the increased mobile use. So actually, you want to ask that is it that the increase, the infertility rate is due to carrying the mobile in the pocket most of the time, or is it due to the husband and wife not giving time to their relationship and spending most of the time in mobile? So wife is also busy in the social media, in the mobile, and husband as well. So they are not giving time to their personal relationship. So is that the reason for the decrease in fertility rate, or is it the carrying the mobile most of the time? You want to ask that?
Yeah, the problem with today's world is people have become pretty rich. They don't use the education in changing their lifestyle. If you have read something is harmful, they don't do it. And they are alternatives, but still they don't want to listen because they think whatever is going there have regressed. I would say this is regression because you want immediate gratification of your needs. They find it convenient. So they put it here. And the data is very clear that 4 hours you keep the mobile in your pocket, the sperm count gets this thing. For about a year, then the sperm count decreases and the quality changes. And now it is not only the men, the women are emulating the men. So they also, they have to keep it all the time, they are carrying in their hand. Even when they come to the dais, they carry the mobile in the hand, they don't keep it in the bag. So there are alternatives, but women are not using the alternatives. See, they only want the easy way, the comfortable way. That is how we are seeing in real practice.
Okay, thank you. Any more who want to give a comment or raise a question or no? Okay, then I thank you for keeping the time. We are able to end on time, and thank you for dealing with the questions that we have had. Very important issue for this country, for neighboring countries, for the Western world, to this view on the family and the importance of the family. Of course, there are many different views about how these things should be handled, and you've given a scientific review of something and shared some of your personal opinions towards the end. So thank you for that. Okay?
For the presentation. Also, I would like to thank my respected Professor Dr. Aaron Holland sir for chairing the session. Now, for the felicitation of our respected chairperson and speaker, I would like to request Professor Dr. Veerabai Maharashtra sir to kindly come forward to present the token of love. I would like to request Professor Dr. Indra Sharma ma'am to come on the stage to receive the token of love. Thank you. Thank you. Similarly, I would like to request Professor Dr. Aaron Holland to come forward to the stage to receive the token of love. Thank you. Thank you, Professor Dr. Nirakar Manstreshwar sir. Welcome back. Hope you all are energized after the delicious sips of hot tea. Now, to continue with the program, we have an audio-visual session coming up. The thematic area of the session is Desai Swastha Bancha. And to present on this thematic area, we have with us Professor Dr. Nirmal Lamithani sir. Professor Dr. Nirmal Lamithani sir is a professor and head of department at Gandaki Medical College Teaching Hospital. And now to chair the session, I would like to request Dr. Sunil Kumar Shah sir and Professor Dr. Indira Sharma ma'am to chair the session. Dr. Sunil Kumar Shah sir is a consultant psychiatrist at Bharatpur Hospital, and Professor Dr. Indira Sharma ma'am is an emeritus professor at National Academy of Medical Sciences. Now, I would like to hand over the floor to the chairpersons. Thank you.
Audiovisual impact has a greater impact when it comes to awareness regarding mental illnesses. This is a very important topic which has been chosen by the presenter. And the presenter is a very renowned person, Professor Nirmal Lamithani. He is well known internationally. He is the professor and head at GMC Teaching Hospital, Pokhara. And he is also the consultant at the Fishtail Hospital. We have been listening to Dr. Nirmal in various international conferences, and what we find that he has done innovative work. It's really nice to have him today as the speaker. So I would request Dr. Nirmal to please go ahead with his presentation.
Thank you, ma'am. Thank you, respected chairperson. And thank you, ma'am, for that introduction. आप मुझे सिर्फ चेला बोल देती तो ठीक था, मैम. Okay. I welcome you all to this audiovisual session, and what this time around our team we had decided that in the conferences when you present text and literatures and studies, it becomes very monotonous. So we are trying to give you different flavor by presenting audiovisually. And I'm sure you'll enjoy it. I would like to make it a very interactive session. And I'll talk briefly about the background and some historical aspect of the illness. According to a survey done by World Health Organization, patients with mental and behavioral problems suffer more due to discrimination and stigma than the illness per se. If we go back to the history of any illness, when first recognized, it goes through a phase of stigmas and discrimination akin to any mental and behavioral disorders. We can take examples of recent COVID-19 or age-old leprosy, typhoid, cholera, malaria, etc., etc. We have heard the news of people being stunned during recent pandemics worldwide as well as in our country. And there was a very disturbing case in Chitwan itself, where one of the doctors was really, I think I would say, traumatized because of this stigma. When doctors in Nepal contracted COVID-19, their houses were cordoned by the neighbors to the point of a social boycott. Health workers working day and night during the pandemic were denied rooms where they were living by the tenants. And I've quoted some of the studies in the bottom. I think that was a cry for help. The study was about attacks against healthcare professionals must stop, especially as the world fights COVID-19. It was in Lancet. Another Lancet article says, I am afraid to be a nurse. That was in the context of serving COVID-19 patient during the pandemic. So, but if we go think about what happens to mental disorders, except for mental and behavioral disorders, other illnesses like I quoted earlier, over time gets acceptance in the society. Discrimination and stigma, though is a global phenomenon, it is even more in countries like Nepal. What is more concerning is not only in general public, stigma is present even among the medicos, even among the fraternity. That is most painful part. I find opportunity in that. So in this awareness video, we have tried to raise the point that with proper treatment, patient with depression or any mental and behavioral disorders can recover and lead a normal life in the community. And the maker of this musical dedicate it to all the beautiful minds who are stigmatized and discriminated by the so-called sane minds. I think we can.
Thank you, Dr. Nirmal. Your audio-visual presentation was quite understandable to us. I think maybe ma'am had difficulty with the language. The concept, the presentation, the story, and your vocal, it was amazing. And I believe along with our regular clinical work and growing enthusiasm in research, these sort of things are very important, and we should reach into our community to reduce stigma and discrimination and to raise awareness in our society. As you have mentioned, like in our part of the world, these things matter more than the other part of the world, and it is very much necessary that we leave our OPD rooms and try to communicate with the community utilizing various sorts of media and audio mediums. So thank you, Dr. Nirmal. Then the floor is open for any questions, suggestions, and comments.
This has been a very good audiovisual presentation highlighting how a patient who's depressed and suicidal gets completely recovered. And this will go a long way in removing the idea that many people think that psychiatric patients can never be cured. So I think it's a very innovative work done by Dr. Nirmal. I think if there are any comments we can ask the speakers. Any other comments?
सबै स्पिचलेस हुनुभयो क्या?
Lamisani sir, we are amazed by your great voice, sir. Now, moving further into the next presentation, I would like to request Dr. Robina Panda to present the drama on the sick mind. Dr. Robina Panda is an MD Psychiatry resident at Gandaki Medical College Teaching Hospital.
Good afternoon, respected Chairperson Dr. Sunil Kumar Saha sir, Professor Dr. Indira Somaman, our respected Professor
Friends,
Dr.
we have a very interesting lecture. Drama sick mind. As I said earlier, that just talking does not really convey often what we want to convey. It is the dramas which have particular themes, which can convey emotions, problems in a much better way. So I think in this way, this is a very good innovative topic. And I would like to hand over the mic to my co-chairperson to introduce the speaker.
Thank you, ma'am. Dr. Robinka, it's wonderful to see that you are doing this sort of works so early in your residency. Actually, I know her since her medical officer job. She used to work with me at the government hospital in our department, and her interest, her patience, her knowledge, everything, like they will be useful for the field of mental health. You should continue doing this sort of work. You can proceed with your presentation.
Good afternoon, respected Chairperson Dr. Sunil Kumar Saha sir, Professor Dr. Indira Sharma ma'am, our respected Professor Dr. Nirmala Misani sir, Professor Dr. Chandra Prasad Serai sir, MD all other consultant psychiatrists, MD resident, medical student, guests and everyone present over here. I am Dr. Robinka Panta, first year resident, Department of Psychiatry, Gandaki Medical College and Teaching Hospital, Pokhara. Today I am going to show a video of drama Birami Man, which was performed on October 15, 2022 on the occasion of World Mental Health Day, October 10. The theme of the World Mental Health Day, October 10, 2022 was Make Mental Health and Well-being for All a Global Priority. In this drama, we have attempted to highlight the few dementia signs, how family plays a role and raise awareness of the condition. The director of the film drama is Mr. Parivartan Karki, script writer is Rajkumar Purasani, producer Professor Dr. Nirmala Misani, BC Production, NRS Entertainment. Now we'll be watching the drama.
Thank you, Dr. Robika Panta. The video beautifully portrayed the prevalent mental illnesses in our country. Now, for the felicitation of our respected speakers, I would like to request Professor Dr. C.P. Serai sir to come on the stage to provide the token of love. I would like to kindly come forward to present the token of love. Sorry. I would like to request Professor Dr. Nirmala Misani sir to kindly come forward to receive the token of love. Thank you. I would like to request Dr. Robika Panta to kindly come forward to receive the token of love. Thank you, Siri sir. Now, for the felicitation of our respected chairperson, I would like to request Dr. Gautam Saha sir, the president of SAC Psychiatric Federation, to kindly come forward to the stage to present the token of love. Now, I would like to request Professor Dr. Indira Sharma ma'am to kindly come forward to receive the token of love. Similarly, I would like to request Dr. Sunil Kumar Saha sir to kindly come forward to receive the token of love. Thank you. After such a flavorful meal, without any further ado, let's begin the next session, that is the writer session. And for the writer session, we have the panelists, Professor Dr. Chandra Prasad Serai, Professor Dr. Dhaneshwar Bhattrai, Dr. D.R. Pokhrel, Sam Atithi Serai. And to moderate the session, I would like to call Kedar Prasad Subedi sir, and I would like to hand over the floor to Kedar Prasad Subedi sir. Thank you.
धन्यवाद म चाहिँ केदार सुवेदी साइकेट्रिक सोसियोलोग र मैले आज यो राइटर सेसनमा सुरु गर्नको लागि हाम्रो सहभागी त न्यून हुनुहुन्छ तैपनि हामी जे जति छौँ हामीले प्रोपर सिक्छौँ हाम्रा गुरुहरू हाम्रा राइटरहरू एकदमै वरिष्ठ राइटरहरूलाई हामीले बोलाएका छौँ, अतिथिको रूपमा निमन्त्रणा गरेका छौँ। उहाँहरूबाट हामीलाई चाहिने महत्त्वपूर्ण कुराहरू सिक्छौँ र अन्तिममा प्रश्नहरू पनि गर्छौँ। यसको लागि तयार हुनु अनुरोध गर्दछु। र म सुरुमै डाक्टर DR पोखरेल चितवनको एकदमै प्रसिद्ध साहित्यकार, उहाँको धेरै प्रकाशित कृतिहरू मैले पनि अध्ययन गरेको छु, मैले पनि हेरेको छु र उहाँलाई म ढिलो नगरिकन मञ्चमा आमन्त्रण गर्दछु र उहाँबाट हामीले राइटरको विशेषता, उहाँले गर्नुपर्ने समय परिस्थिति र सब्जेक्ट छनौटहरूदेखि लिएर उहाँले आफ्नो प्रस्तुति दिनलाई हार्दिक अनुरोध गर्दछु। सर अगाडि हुनुहुन्छ। हस्, धन्यवाद।
भनेर एकदम 2-4वटा कुराहरू संक्षिप्तमा 2-4वटा कुराहरू राख्नलाई चाहिँ भन्नुभएको छ। मेरो परिचय, म DR पोखरेल, म अहिले फ्रिल्यान्सर हुँ, घर कुरुवार, र मेरा 19वटा बुकहरू छन्। मेरो समीक्षाका, अनुसन्धानका अनि त्यसपछि निबन्धका तीनटा विधामा मैले लेख्ने गरेको छु। र डाक्टर सेडाई साहबका चाहिँ बुकहरू, खास त मनोरोग सम्बन्धीका बुकहरू पढ्न पाएको छु, खास त डिप्रेसन सम्बन्धी बुकहरू पढ्न पाएको छु। त्यसले चाहिँ डाक्टर साहब एउटा यो क्षेत्रमा लागिराख्नु भएको, एउटा उपचारमा लागिराख्नु भएको भएर पनि बुक पनि लेखेर चाहिँ आउनुभएको छ। उहाँ एउटा राइटरको रूपमा स्थापित भइसक्नु भएको छ। हाम्रो धनेश्वर सर समालोचनाहरू गर्नुहुन्छ र कलेजहरूमा साइकोलोजी पनि पढाउनुहुन्छ, मनोविश्लेषण गरिएका समालोचनाहरू पढाउनुहुन्छ। त्यस्तै श्यामजी अतिथि उहाँ पुरानो शिक्षा अधिकारी हुनुहुन्छ, पूर्व शिक्षा अधिकारी, र अहिले साहित्य लेखन, खास त निबन्ध लेखन, कवितामा उहाँ संलग्न हुनुहुन्छ। मैले आज अध्यक्षज्यूको मैले त्यति धेरै थाहा छैन, उहाँ बताउनु भएअनुसार उहाँ पनि चाहिँ यो साइकियाट्रिक क्षेत्रमा धेरै लेखहरू लेखिराख्नु भएको छ भन्ने मैले सुनेको छु। मैले चाहिँ मेरो आफ्नो सानो परिचय के भने, म ओखलढुङ्गामा जन्मेको हुँ र यहाँ चितवनमा 50 सालमा म यहाँ आएँ। योभन्दा अगाडि मैले इन्जिनियरिङ डिप्लोमा चाहिँ गरेको हुँ। इन्जिनियरिङ डिप्लोमा गरेर 3 वर्ष जागिर खाएँ, अनि 10-12 वर्ष चाहिँ पार्टीको झोला बोकेर चाहिँ हिँडेँ। त्यसपछि पत्रकारिता गरेँ, अनि त्यसपछि साहित्य क्षेत्रमा लागेँ र अहिले केही समय पछाडि अनुसन्धानको क्षेत्रमा काम गरिरहेको छु। मैले यो हाम्रो सेडाई साहबले भनेअनुसार मैले आफ्नो परिचय राखेँ र यो मेरो एउटा आफ्नो स्वास्थ्यबारे पनि मैले बताउनु पर्ने हुन्छ। मैले त्यति सभामा बोल्नलाई म लेख्न सक्छु, तर सभामा बोल्ने बेलामा मलाई एक खालको भय पनि हुन्छ। डाक्टर साहबहरूलाई यो कुरा राखिहालौँ भनेर लागेको। मैले अलिक पहिले पढेँ, हामी कहाँ साहित्यका 4वटा विधाहरू छन्, कविता, आख्यानमा उपन्यास र कथा पर्छ, अनि त्यसपछि नाटक र निबन्ध। यी 4वटा विधाहरू छन् र नेपालमा 4वटा विधामा मनोसंसारको प्रयोग भएको छ। मन नै त हो, कविहरू मनबाटै चाहिँ प्रभावित हुन्छन्, उनका मनमा भावनाहरू उठ्छन्, उनका धेरै अनुभूतिहरू हुन्छन् र विचार, अनुभूति र इमोसन, भावना भनौँ न, भावनाहरूबाट उनीहरू सञ्चालित हुन्छन्। र कविहरू भनिसकेपछि हामी कहाँ एउटा छवि पनि छ। कविको छवि के छ भने, कविहरू त्यति व्यवस्थित हुँदैनन्, एक सुरे हुन्छन्, अनि कपाल पालेका, दाढी पालेका, चुरोड खाने, अब कपडाको त्यति वास्ता नगर्ने, घर व्यवहारको पनि वास्ता नगर्ने, त्यस्ता खालका हुन्छन् भन्ने एउटा चाहिँ छवि चाहिँ हाम्रो समाजमा छ। र त्यसको उदाहरणलाई देवकोटालाई पनि त्यसको उदाहरणको रूपमा लिन सकिन्छ। देवकोटा चाहिँ बसेर चाहिँ चुरोड खाने र बिस्कुट सुकाउन दिएको मकै समेत चाहिँ सबै खाएर सक्ने खालको हुनुहुन्थ्यो एक सुरे। त यो एक सुरे किन हुन्छन् साहित्यकारहरू। अब यो डाक्टर साहबहरूले विश्लेषण गर्ने कुरा हो, तर यस्तो खालको छवि छ। तर मलाई चाहिँ के लाग्छ भने कवि भनेको पनि अथवा साहित्यकार भनेको पनि यो कुनै अनुभूतिको मात्रै कुरा होइन, विचार नै हो। यो साहित्य पनि एउटा विचार, कला, साहित्य र कला पनि विचारकै एउटा अङ्ग हो भन्ने मलाई लाग्दछ। र हामी कहाँ यहाँ डाक्टर साहब धनेश्वर डाक्टर साहबले, श्यामजी अतिथिले कविताको क्षेत्रमा, काव्यको क्षेत्रमा कसरी प्रयोग भएको छ भनेर उहाँहरूले राख्नुहुनेछ। मैले आख्यानको क्षेत्रमा कसरी मनोविश्लेषण भएको छ, कसरी मनोसंसार चाहिँ प्रयोग भएको छ भनेर यहाँसित केही राख्दछु। अब यो साहित्य र मनोविज्ञानको भनौँ न एउटा एकदमै गहिरो नाता छ, एकदम जोडिएका छन् यिनीहरू। हाम्रो अब यो इडिपस रेक्स भन्ने एकदम पुरानो ईसापूर्व 400तिरको एउटा चाहिँ यो नाटक हो। त्यसमा चाहिँ त्यो नाटकमा के हुन्छ भने त्यहाँको एउटा पात्र इडिपस भन्ने पात्र, उनी राजा पनि थिए। अब उनले कति के दुःख पाए उनको अहिले त्यतातिर नजाउँ, तर उनले चाहिँ आफ्नो बाबुलाई चाहिँ मारेर आमासित बिहा गर्छन् र त्यो चाहिँ मातृपक्षको अथवा आमाप्रतिको त्यो जुन उनको चाहना चाख हो अथवा आमाप्रतिको जुन चाहिँ त्यो खालको प्रभाव हो, ममता हो त्यसलाई लिएर चाहिँ सिगमन्ड फ्रायडले इडिपस कम्प्लेक्स भनेर चाहिँ राख्नुभयो। यो इडिपस कम्प्लेक्सको चाहिँ कुराहरू त्यसरी आउँछन्। र हाम्रो यहाँ पूर्वमा विरूपाक्ष छन्। विरूपाक्ष भनेको किराँत कालका एकजना किराँत हुन्। अब उनी घरबाट निस्केका थिए र कहीँ बास बस्ने बेलामा आमा र उनी सँगै भए र आमालाई उनी सम्भोग गर्छन्। हाम्रो यहाँ पूर्वमा पनि छ। यो पूर्वको र पश्चिमको चाहिँ यो मातृपक्षसितको एउटा बच्चाको आमाप्रतिको चाहिँ चाहना जुन हो, त्यो चाहना चाहिँ पूर्व र पश्चिममा एकैचोटि चाहिँ निस्केको देखिन्छ। हाम्रो यहाँ किराँतकाल, पश्चिममा चाहिँ ईसापूर्व 400 भनेपछि एकैतिरको चाहिँ कुरा हो भन्ने मलाई लाग्दछ। र अनि यो पछिबाट आएर अब 19औँ शताब्दीमा आएर सिगमन्ड फ्रायड आउनुभयो, अरू जुङहरू आउनुभयो, अरू धेरै चाहिँ मनोविज्ञान सम्बन्धी चाहिँ धेरै दर्शकहरू चाहिँ आउनुभयो र उहाँहरूले चाहिँ मान्छेलाई चाहिँ अब मान्छेभित्र चाहिँ अहम हुन्छ, इड हुन्छ, अनि त्यसपछि सुपर अहम हुन्छ भनेर चाहिँ यसरी चाहिँ उहाँहरूले राख्नुभयो। र हाम्रो पूर्वमा भन्ने हो भने चाहिँ बुद्धले चाहिँ मनको धेरै गर्नुभयो। बुद्धभन्दा अगाडि सारा पूर्वीय दर्शनमा चाहिँ आत्माको कुरा आउँछ। अनि तर बुद्धले चाहिँ आत्माको कुरा गर्नु भएन, उहाँले मनको कुरा गर्नुभयो र मनलाई चाहिँ 52वटा तहमा चाहिँ बुद्धले बाँड्नु भएको छ। र पूर्वमा चाहिँ सबभन्दा पहिले मनको अध्ययन चाहिँ पूर्वमा सुरु भएको देखिन्छ र त्यो चाहिँ बुद्धबाट सुरु भएको देखिन्छ। मैले अघि नै भने। अनि पश्चिमको र पूर्वको अलिकति फरक के छ भने पूर्वमा त्यही कुरा जुन कुरा पूर्वमा चाहिँ विरूपाक्षको आउँछ, विरूपाक्षले आमासित सम्भोग गर्छ, पश्चिममा चाहिँ इडिपसले आमासित बिहा गर्छ। त्यो कुरालाई चाहिँ पश्चिमले अलिकति अगाडि लिएर आयो, त्यसलाई सैद्धान्तिकरण गर्यो। हाम्रो पूर्वमा त्यसो हुन सकेन, किनभने हाम्रो संस्कृति मनोविज्ञान जुन छ, हाम्रो संस्कृतिमा हामीले आमालाई मातृदेवो भव भन्छौँ। अब हामीले त्यो सोच्नै सक्दैनौँ चाहिँ। हामी पूर्वका मान्छेले कतिपय कुरा सोच्नै सक्दा रहन्छौँ, जुन कुरा पश्चिमका मान्छेहरूले चाहिँ सहज रूपमा सोच्न सक्दा रहेछन् भन्ने मलाई लाग्यो। अब यो नेपालमा चाहिँ 2018 सालमा विजय मल्लले अनुराधा भन्ने एउटा चाहिँ उपन्यास चाहिँ लेख्नुभयो। त्यसमा सर्वाधिक जति पनि अब मनोविज्ञानका जति पनि कुराहरूलाई सैद्धान्तिकरण गरिएको थियो, त्यसको प्रयोग चाहिँ उहाँले अनुराधामा गरेको हामी चाहिँ पाउँछौँ। अब यो अनुराधा उपन्यासमा अनुराधा चाहिँ मूल पात्र हो अनि अनुराधा चाहिँ काठमाडौँको एउटा चाहिँ व्यापारी घरानाकी ज्यादै सम्पन्न घरानाकी चाहिँ छोरी हुन् उनलाई चाहिँ उनको बाउ चाहिँ लासामा व्यापार गर्थे उनलाई चाहिँ कालिम्पोङमा चाहिँ पढ्न राखिएको थियो बाउ चाहिँ घर नआउने उनलाई भेट्न चाहिँ जाने भएकोले उनको आमा र दिदीहरूको त बिहा भइसकेको थियो तर दिदीहरू र आमाले चाहिँ के गरे भन्दाखेरि त्यो द्वेष उनीप्रतिको ईर्ष्या आमाले त ती अनुराधालाई चाहिँ बाउले मात्रै भेट्न जाने बाउ हामी कहाँ नआउने भनेर अनुराधालाई चाहिँ अनुराधाप्रति द्वेष चाहिँ उनले राखिन् अनि अनुराधालाई सौता जस्तै व्यवहार चाहिँ गरेका छिन् र अनुराधालाई चाहिँ अब यसलाई बाउको त्यो नजरबाट चाहिँ यसलाई हटाउनु पर्यो भनेर एउटा काठमाडौँकै एकजना धनाढ्य मान्छेसित दोस्रो बिहा गरिदिने धनाढ्य मान्छेको दोस्रो बिहा उसलाई सौतामाथि दिने भनेर चाहिँ उनी कालिम्पोङमा पढिराखेका थिइन् अनि कालिम्पोङमा पढिसकेपछि उनी चाहिँ उच्च शिक्षाको लागि चाहिँ लखनऊ आएकी थिइन् अनि त्यही बेलामा चाहिँ यहाँ बोलाइन्छ काठमाडौँमा र ल चाँडो आऊ यहाँ आमा बिरामी भयो भनेर भन्छन् तर आमा र दिदीहरू मिलेर त्यो धनाढ्यसित कुरा मिलाएर उनका चाहिँ त्यहाँ एउटा पूजा लगाएर पूजामै माला लगाउने र एउटा अप्रत्यक्ष रूपमा उनीहरूको स्वयंवर गराइदिने भनेर ल्याएको हुन्छ त्यो कुरा उनले थाहा पाउँछन् उनले माला फ्याँक्छिन् उनले त्यसको विरोध गर्छिन् तर माला दुईटैले लगाइसकेका थिए त्यसपछि उनलाई के भयो भनेदेखि त्यो धनाढ्यप्रति चाहिँ उनलाई भित्र चाहिँ बदलाको एउटा भावना चाहिँ आयो उनले त्यसलाई मार्छु भनेर हातमा छुरी लिएर चाहिँ उनको घरमा चाहिँ गएकी थिइन् तर त्यहाँ कस्तो वातावरण भयो भने घरमा चाहिँ ओहो नयाँ दुलै घर पस्न आई भनेर त्यहाँ चाहिँ उनलाई स्वागत गरेपछि उनलाई पनि के लाग्यो भन्दाखेरि उनको एउटा चाहिँ त्यो हत्या गर्ने त्यसको हत्या गर्छु बदलाको एउटा भावना त आएको थियो एउटा भावना त्यो अर्को चाहिँ उनको इगोले चाहिँ के गर्यो भन्दाखेरि होइन मैले यसलाई मार्नु भन्दा यसलाई सताएर यसलाई पनि कुनै दण्ड दिएर चाहिँ यसलाई चाहिँ सताउनु यसलाई पीडा दिनु चाहिँ उचित हो भनेर उनी द्वन्द्वमा परिन् मार्ने कि पीडा दिने भन्ने द्वन्द्वमा परिन् त्यो द्वन्द्वमा पढ्दै चाहिँ तिनी विक्षिप्त भइन् हो त्यो एउटा कथा चाहिँ यसरी चाहिँ आउँछ यदि अब त्यहाँ के छ भने बाउप्रति उनको चाहिँ अलि बढी लगाव देखिन्छ अनि आमाले चाहिँ उनलाई चाहिँ सौता जस्तो चाहिँ ठानेकी छन् अनि त्यसपछि दिदीहरूले पनि त्यो बाउले एकपक्ष अनुराधलाई मात्रै माया गर्यो भनेर त्यो ध्यान हटाउन चाहिँ चाहन्छन् र उनी चाहिँ आफूलाई धोका दिनेलाई चाहिँ मार्न चाहन्छन् तर फेरि उनको एउटा भित्रको चाहिँ त्यो उनी शिक्षित थिइन् रूपवती थिइन् त्यहाँ पढेकी अङ्ग्रेजी स्कुलमा पढेकी त्यो भएकोले उनले चाहिँ आफूलाई रोक्छिन् चाहिँ त यसरी चाहिँ उनले चाहिँ आफूलाई अब आफ्नो भित्र विध्वंस भएको हुन्छ उनको चाहिँ न उनी हत्या गरेर आफूलाई शीतल पार्न सक्छिन् न चाहिँ हत्याको भावनाबाट मुक्त भएर चाहिँ त्यहाँ बिहा गरेर बस्न सक्छिन् त्यहाँ बिहा पनि गर्दैनन् त्यो घर छाडेर हिँड्छन् यसरी उनी विध्वंस भएको अनुराधा चाहिँ आफ्नै मनको द्वन्द्वहरूमा परेर विध्वंस भएको चाहिँ यसरी उल्लेख भएको छ यसै गरी अरू पनि धेरै चाहिँ त्यस्तै खालका मनोविज्ञानको असाध्यै सूक्ष्म खालको मनोविज्ञान प्रयोग गरिएका धेरै चाहिँ आख्यानहरू लेख्नु भएको छ यसमा गोविन्दबहादुर मल्ल भयो विजय मल्ल भइहाल्नुभयो इन्द्रबहादुर राई पारिजात ध्रुवचन्द्र गौतम विश्वेश्वर प्रसाद कोइराला भवानी भिक्षु अनि तारिणी प्रसाद कोइराला आदि धेरै हुनुहुन्छ धेरै चाहिँ स्रष्टाहरू हुन्छ जसले यसलाई चाहिँ प्रयोग गर्नुभयो अब यो साहित्यकारले त यो लेख्नुभयो तर त्यसलाई विध्वंस हुन नदिनुको लागि अनुराधालाई विध्वंस हुन नदिनुको लागि चाहिँ आजको यहाँहरूले जुन चिकित्सा गरिराख्नु भएको छ त्यो चिकित्साले के गर्यो भने कस्तो खालको काउन्सिलिङ गर्यो भने कस्तो खालको एडभाइस चाहिँ यहाँहरूले दिनुभयो भने उनी विध्वंस हुनबाट रोकिन्छन् उनीको जीवन चाहिँ सहज हुन्छ उनी विवाहित भएर बस्न सक्छिन् यो कुरा चाहिँ हजुरहरूको जिम्मामा यति भन्दै म यहाँहरूसित बिदा लिएँ धन्यवाद
वरिष्ठ साहित्यकार डिआर पोखरेलज्यू अब म डाक्टर धनेश्वर भट्टराईज्यूलाई आफ्ना कृति र आफ्ना भनाइहरू राखिदिनु हुन हार्दिक अनुरोध गर्दछु। उहाँ समालोचक हुनुहुन्छ, साहित्यमा रुचि राख्नुहुन्छ, धेरै पुस्तकहरू प्रकाशित छन् उहाँका, र उहाँले कलेजमा पनि पढाउनुहुन्छ। उहाँको हामी केही सिक्छौँ उहाँबाट। धन्यवाद।
सर्वप्रथम सबैमा नमस्कार। नाम भनिहाल्नुभयो, धनेश्वर भट्टराई, र म अध्यापन कार्य गर्छु र कविता लेख्छु। साहित्यको एउटा विद्यार्थी हो। मैले अलिकति असामान्य रूप देखाएँ भने तपाईँहरूले मलाई फेरि औषधि गर्न बोलाउनु बेर मान्नुहुन्न। त्यही भएर म आफूलाई तयार एकदम सन्तुलित रूपमा बोल्नु पनि मैले पर्छ। त्यही भएर आजका सभापतिज्यू, विशिष्ट उपस्थित सम्पूर्ण डाक्टर साहबहरू, मनोचिकित्सकहरू र आदरणीय डिआर सर, श्याम अतिथि सर र सम्पूर्ण यहाँ अन्य व्यक्तित्वहरू, म विशेषतः मेरो परिचय दिँदा तनहुँ जिल्लाको रायपुर शुक्ला गण्डकी नगरपालिका 11 उहाँ जन्मेको, पेटभरि भात खुवाउने भनेर होला सायद बुबाहरूले डोकामा राखेर 21 सालमा मधेस झारेको, चितवन आएर भात खाएको। मेरो परिचय त्यति हो। र अहिलेको अवस्थामा अहिलेका किन झर्छन्, त्यो सुविधाका निम्ति झर्छन्, तर हाम्रो पालोमा हामी केटाकेटी हुँदा झारेको कारण के थियो त भन्दा पहाडमा अति दुःख थियो, उब्जनीलाई श्रम धेरै थियो, आम्दानी कम थियो। यहाँ चाहिँ कम्तीमा पेटभरि भात खुवाउन पाइन्छ भनेर मधेस झारेको अनुमान म गर्छु र मैले त्यो लेखेको पनि छु। र अब कृतिहरू छन्, आफ्नै ठाउँमा छन्, 8-10वटा कृतिहरू छन्, ती पनि छोडिदिउँ। म पढाउँछु, त्यो पनि छोडिदिउँ। तर आज म साँच्चै भन्यो भने पढ्न पनि आएको थिएँ मानसिक स्वास्थ्य बारेमा। अब स्वास्थ्य मानिस मनद्वारा सञ्चालित हुन्छ, त्यसमा अन्यथा केही पनि मान्दिनँ मैले। जे जति सिर्जना भएको छ, जे जति आविष्कार भएको छ, जे जति आज यो संसारमा हामी माझ उपलब्ध छ, त्यो सबै मनको करामत हो। मानवीय आवश्यकता, चाहना र मनको करामत हो र त्यसले पाएको छ। तर म अब विशेष गरी मेरो परिचय दिएपछि म कता जान चाहन्छु भन्दा के छ त भने विशेष गरी मानिसमा के रहन्छ त भन्दा मान्छेको मनका प्राप्तव्य चिजहरू हुन्छन्, आकाङ्क्षाहरू हुन्छन् र त्यो प्राप्तिका निम्ति मानिस प्रयास गर्छ र उसले पाएका कुराहरू जे जति छन् त्यसमा सन्तुष्टि बस्दैन। असन्तुष्ट मन सधैँ तन्किन्छ, लम्किन्छ, प्रयास गर्छ र धेरै पाउन खोज्छ तर पाउँदैन सोचे जति। ती पनि फेरि भित्रै जान्छन्, मनमै हुन्छ, कुण्ठित भएर बसेका हुन्छन्, दमित रूपमा बसेका हुन्छन्, ती कुण्ठित हुन्छन्। म व्याख्या गर्नतिर जान्न, फ्राइडको साइकोलोजी या मनका तह, इगो, सुपर इगोतिर म जान्न, म त्यो पनि जान्दिनँ। हो, म मास्टर डिग्रीलाई मनोवैज्ञानिक समालोचना चाहिँ पढाउँछु वीरेन्द्र क्याम्पसमा, वीरेन्द्र बहुमुखी क्याम्पसमा त्यो पढाउँछु। तर पनि म त्यता जान चाहन्न, म मात्र साहित्यको कोणबाट हेर्छु। किनभने जुन मानिसभित्र रहेका सुसुप्त आकाङ्क्षाहरू जब सल्बलाउँछन्, हो त्यो बेला मानिसको मन सक्रिय हुन्छ र त्यहाँबाट केही राम्रा पनि गर्छ, त्यसले नराम्रा पनि गर्छ। जब अतृप्त र नपुगेका, अनिच्छित तर अप्राप्य त्यस्ता चिजहरू, चाहेका तर नपाएका कुराहरूले मान्छेलाई अगाडि लान्छ। हामी हेर्छौँ साहित्यमा त्यसको प्रयोग कसरी त अलिकति भन्छु। साह्रै नजिकको प्यारो वस्तु वा मान्छे मर्दा हामी किन रुन्छौँ? किन हामीलाई बिछोडको अनुभूति हुन्छ? प्रणयमा, यानि अहिलेको भाषा त नयाँ भाषा लभ हो, तर म प्रणय भन्छु। प्रणयमा किन हामी चुर्लुम्म भन्छौँ दुनियाँ छोडेर? अर्कातिर हेर्दा, फेरि हेर्दा हामी कसैले चुनौती दियो भने ल सक्सेस भने, तेरो बाउले, आमाले दुध खुवाएको र बाउले जन्माएको भने आइज पाखुरा खेल्छन्। त्यो के हो? हाम्रा मनका रूप हुन्। मैले भन्नु खोजेको मनका धेरै रूप छन्। किन भन्दा यो सबै जब हामी मिठो चिज खाइरहेछौँ, सिनो सडेको सिनो अगाडि फ्याक्क झऱ्यो भनेदेखि दुर्गन्ध फैलियो भने नाक पुग्दै छिछिर थुतु उति बेलै हुन्छ। मान्छेले पहिले दिमागले थाहा पाउँछ, त्यही सायद दिमाग भनेको त्यो मन हो। त्यही भएर म यसो हेर्दै जान्छु। किन भन्दा दुःख र पीडा संसारको नश्वरता देखेपछि हे जति गरे पनि यो संसार केही रहेछ, बेकार छ भनेर बैरागी भएर हिँड्छन् मान्छे। धनी छन्, नपुगेको छैन, पढेका छन्, तर जोगी जस्ता छन्। किन? त्यो के को काम? त्यो पनि मनकै काम। मैले भन्नु खोजेको मनका विविध तह छन्, रूप छन्, प्रकार छन्, तर त्यो के अनुसार छ त भन्दा त्यो भाव हो। एउटा भनौँ मनमा भावहरू हुन्छन्। ती भावहरू हामीले जन्मजात रूपमा, पारिवारिक रूपमा, वंशगत रूपमा, संस्कारगत रूपमा जतिसुकै आधुनिक हुँ भन्नुहोस्, तर जन्मजात पारिवारिक जातीय संस्कारगत भावनात्मक रूपमा बोकेर आएको झर्या हिस्सा सम्झिन्छ। आमा मम्मी भन्न थाले आमा नै भन्दैनन् अहिलेकाले, तर जब टाउको बेसेरी ठोकिन्छ आमा भन्छ त बल्ल आमा सम्झिन्छ जब दुःख पर्छ। किनभने त्यो संस्कार हो हामीलाई, हाम्रो मनको संस्कार हो, हामीले बिर्सिन्नौँ, मनले त्यो दिन्छ। र यसरी हेर्दा यो साहित्यमा यही कुरा व्यक्त भएको हुन्छ, सबै कुरो र देखाइदिन्छ साहित्यले मनलाई। साहित्यमा मानसिक रूप भनेका यिनै छन् भने यो पूर्व र पश्चिम, अघि नै भने पूर्व र पश्चिमको अघि कुरा आएको थियो। पूर्व र पश्चिममा के फरक छ त? पूर्वमा पनि छ, पश्चिममा पनि छ। ईसा पूर्व, पश्चिममा ईसा पूर्व 4औं शताब्दीमा सोक्रेटसका चेला प्लेटोले साहित्यकारलाई युनानी गणराज्यबाट ससम्मान साहित्यकारलाई देश निकाला गरेका थिए। ल यदि साहित्य र मनको पढ्ने भए त्यहाँनिर गएर पढ्नुपर्छ सबैले। किनभने किन निकाले त? साहित्यकारहरू मनमौजी हुन्छन्, भावनामा रमाउँछन्, डुब्छन्। तिनीहरूले लेखेका कुरा पढेपछि सामान्य जनता उद्वेलित हुन्छ, जुरुक्क उठ्छ, जुरमुराउँछ, हेर्दै अगाडि जान्छ र जस्तो सामना गर्न पनि ऊ पछि हट्दैन, कमजोरमा पनि तागत भरिए झैँ हुन्छ। र साहित्यको बल त्यस्तो हुन्छ भन्ने प्लेटोलाई थाहा थियो। त्यही भएर निकाले, त्यो आक्षेप लगाए, साहित्यकारमाथि आक्षेप लगाए, निकाले। यिनीहरूले गणतन्त्रलाई भाँड्छन् भनेर निकालेका थिए। तर तिनका चेला फेरि एरिस्टोटलले के गरे त? आफ्ना गुरुका भनाइलाई फेरि अप्रत्यक्ष रूपमा घुमाउरो पाराले खण्डन गर्दै साहित्यले बराल्ने, उराल्ने, भड्याउने होइन, साहित्यले त मनलाई शान्त र स्वच्छ बनाएर तृप्ति दिन्छ भनेर अर्को सिद्धान्त निकाले, क्याथर्सिस यानी विरेचन सिद्धान्त हो। यसरी पश्चिममा यसरी आए साहित्य भने पूर्वमा के भयो त? पूर्वमा पनि त्यही भयो। पूर्वमा त भन्यो के अरे कवि करौती भन्न आयो। पूर्वमा एउटा छ यथैव रोचते अस्मिन् तथैव काव्य निर्माता भन्ने चाहिँ प्रजापति भन्यो कविलाई पूर्वमा। किन भन्दा उसले जस्तो चाह्यो त्यही संसार निर्माण गरेर बनाउन सक्छ, नयाँ दुनियाँ भन्यो। र यसरी अगाडि बढ्दै जाँदा पूर्वमा चाहिँ विशेष गरी साहित्यको आनन्दलाई के भन्यो त? ब्रह्मानन्द सहोदर। अनि कुन सिद्धान्त आयो त? साधारणीकरण सिद्धान्त पूर्वमा आयो। न तेरो न मेरो, कसैको थाहा हुँदैन, मजाले आनन्द दिने, यो सानो हो, यो तल्लो जात हो, यो गरिब हो, यो बाउ हो, यो आमा हो, यो परको नजिकको कोही थाहा नहुने, स्वपर भेद हरण भएको बेला साधारणीकरण। जस्तो म भनिदिउँ, तपाईँहरू फिल्म हेर्नुहुन्छ, एक्लै बसेर चलचित्र फिल्म हेरिरहेको बेलामा तपाईँहरू आफै कति नजानिदो पात्रलाई आफ्नो बनाउनुहुन्छ र अनि हेर्दै जानुहुन्छ, नाटक हेर्दै जानुहुन्छ, त्यसको दुःखमा दुखी हुनुहुन्छ, खुसीमा उफ्रिनुहुन्छ, एक्लै कोठामा एक्लै बसेर हेर्नुहुन्छ, तर तपाईँ आफै एक्लै स्याबास भन्दै ताली पिट्नुहुन्छ। अनि कोही नाटक हेऱ्यो, फिल्म हेऱ्यो, आँखाभरि गहभरि आँसु चुहाउँदै पुस्दै बाहिर निस्किया छ, बाहिर आएर कस्तो रहेछ त नाटक, सो सोद्धा भन्छ साह्रै राम्रो, आहा कति राम्रो, रुने पनि राम्रो हुन्छ, जसले रुवाउँछ त्यो राम्रो हो, तर राम्रो हो किनकि मनको कल्मस धोइदियो, त्यसले मन सफा पारिदियो। साहित्यको एउटा प्रस्तुति त्यो हो। यसरी हेर्दा मनोविज्ञान भन्ने यो मनोवैज्ञानिक रूपमा साइकियाट्रिकको यो सम्मेलनमा राइटर सेसनमा उभिएर बोल्दा मनोविज्ञान नै भनेर जसलाई हामी भन्छौँ, यी मैले भनेका अहिलेसम्मका के थिए? असचेत रूपमा, अवैज्ञानिक रूपमा, अव्यवस्थित रूपमा पुरातन कालदेखि प्रचलनमा आएका कुरा थिए। तर व्यवस्थित वैज्ञानिक मनको विज्ञान भएर मनोविज्ञान भयो भने व्यवस्थित र वैज्ञानिक अध्ययन गर्न थालेको 20औं शताब्दी प्रायबाट सुरु भयो। अनि एडलरले उनले सम्पूर्ण अझ मोटामोटीहरू छोडिदिउँ, हजुरहरूलाई थाहा छ, हजुरहरू त्यो क्षेत्रको विज्ञ हो, तर हामी त सामान्य पाठकको बाहिरबाट तपाईँ हजुरहरूले भन्दा श्रोता हुन पाए अझ जान्ने कुरो हो। तर फ्रायडले सम्पूर्ण मानवीय क्रियाकलापलाई एउटै उसमा राखिदिए, यौनमा, काम शक्तिमा समेटे उनले। तर उनका चेला अल्फ्रेड एडलरले मानेनन्। त्यो सम्पूर्ण मान्छे मानवीय कर्म के लागि हो त भन्दा हीनता बोधी ग्रन्थीलाई नष्ट गरेर उच्चता बोधी अवस्था प्राप्त गर्न गर्छ भने उनले त्यसको विरुद्धमा फेरि अर्का कार्ल गुस्ताव जुङले के भने त भन्दा उनले अर्को निष्कर्ष निकाले। उनले अवचेतन त अवचेतनलाई दुई किसिमले बाँडे, व्यक्तिगत अवचेतन र सामूहिक अवचेतन। सामूहिक अवचेतनभित्र समाज मन, अझ भनौँ जुङकै कुराबाट समाज मनोविज्ञान आयो यो दुनियाँमा। समाज मनोविज्ञानको सूत्रपातकर्ता जुङ हुन्, कार्ल गुस्ताव जुङ, र त्यहाँबाट उनले सामूहिक सामाजिक मनोविज्ञानलाई लिए। हुन पनि आज सामाजिक मनोविज्ञान कुनै ठाउँमा स्पेसल जाउँ हामी, त्यहाँ प्रत्येकले त्यही भनिरहेको हुन्छ, हामी त यस्तो, हामी त यहाँको, हामी यो त्यो के हो? समाज मनोविज्ञान हो, आज पनि छ। त्यो हिसाबले आयो भने अब छोडिदिउँ, उता नजाउँ, म त टाइम फेरि धेरै होला, अघि धेरै भइसक्यो जस्तो लाग्थ्यो। र अब नेपाली साहित्यमा जाउँ। नेपाली साहित्यमा कहिलेदेखि आएको थियो? विक्रम सम्वत 1991 को विश्वेश्वर प्रसादको हिरालाको चन्द्रवदन भन्ने कथाबाट नेपाली साहित्यमा भित्रियो। त्यसपछि लगातार आए, धेरै आए, भवानी भिक्षु आए, अनि मल्लबन्धुहरू आए, र उपन्यासका रूपमा पहिलो पटक पल्लो घरको झ्याल 2016 गोविन्द गोठालेको उपन्यास देखा पर्यो। अघि अनुराधाको सरले भनिसक्नुभयो। त्यसपछि नाटकमा आए, अनगिन्ती नाटक छन्। यसरी यो के भयो त भन्दा मनोवैज्ञानिक चर्चा अगाडि आयो र साहित्य र मनोविज्ञानका बिचमा यसरी राम्रोसँग हेर्नुपर्दा दाँच्नुपर्दा म त्यता पनि लाग्दिनँ। तैपनि मनोविज्ञानका प्रकारहरूलाई हेर्दा धेरै छन्। सामान्य मनोविज्ञान छ, समाज मनोविज्ञान छ, वैयक्तिक मनोविज्ञान छ, बाल मनोविज्ञान छ, यौन मनोविज्ञान छ। त्यति मात्र होइन, अपराध मनोविज्ञान छ। सबै यो साहित्यमा पढ्नुपर्ने कुराहरू यी हुन्। अपराध मनोविज्ञानको सानो दिन्छु। किस्ने र खुकुरी भन्ने कथा मल्लबन्धुको के गर्छ? हतियार पाउँछ, हतियारको अहिलेको हतियारको दुरुपयोग देखाउँछ कि यसो खुकुरी किन्छ, सिरुपाकै खुकुरी बेच्न ल्याएको किन्छ र सिरानीमा लुकाएर राख्छ। श्रीमतीलाई पनि भन्दैन, भर्खर बिहा गरेकी चटक्क परेकी राम्री श्रीमती थिइन्। बेलुका आई, श्रीमती सुतेको ढिलो आयो, आएर यसो हेऱ्यो, श्रीमतीको घाँटी सेतो गर्दन सानो मुठीले अँठ्याउँदा पनि च्याप्प एउटा मुठीमा आउने देख्छ। अनि यसो हेर्छ, हो सुतेको मान्छे उठ्यो, खुकुरी हेर्छु भनेर फेरि खुकुरी झिक्यो। तन्काई यताउता फर्काइ हेऱ्यो। अनि त्यो हेर्दा हेर्दै उसलाई मनलाई कसरी चाहिँ मन जान्छ भन्ने। अनि त्यहाँबाट हेर्दै श्रीमतीको गर्दन हेऱ्यो, सेतो सानो एक मुठी मुठीले समाउन मिल्ने सानो गर्दन सुलुक्क परेको देख्यो। अनि फेरि हतियार राख्यो, आफै लजायो, अनि फेरि एकछिनपछि खेलायो, हेऱ्यो कस्तो हुन्थ्यो होला, च्याप्प काट्ने भए सम्झ्यो पनि। अनि तर्स्यो, एकछिनपछि विचार गर्दा कतिखेर काटेछ, हेर्नु काटेछ। के हो त मनोविज्ञान? अर्को कथा छ भाँडो विजय मल्लको। एउटा गरिब केटो 18 18 वर्ष पुगेको छ, एउटी तरुणी घरबेटी केटी नाङ्गै नुहाउँछ त्यहाँ बाहिर बसेर, त्यही धारामा बसेर भाँडो भान्डा लगाउँछ दिनदिनै। तिनीहरूका बिचमा के हुने हो त? त्यसले सिर्जना गरेको परिस्थिति मनोविज्ञान त्यहाँ छ। अरू केही न पढे लेखेको छ भन्दैमा, उमेर गयो भन्दैमा छोरी मान्छेलाई चाहिँ नि धनी मान्छेसँग 45 वर्ष 50 वर्ष धनी मान्छेसँग बिहा गरिदिन्छन्। बिहा गरिदिएपछि अन्तिममा चाहिँ नि यति थुपार दिएको छ कि सम्पत्ति दराजभरि यति छन् कि उसका कपडाहरू लत्ता कपडा तर अन्तिममा के हुन्छ त? श्रीमती के गर्छ त? एक दिन साडीको पासो लाएर त्यहीँ मर्दिन्छ। किन हो त त्यो? नपुगेर हो त? पिटेर हो त? माया नगरेर हो त? खान नपाएर हो त? होइन, उसलाई अस्मिता, आफ्नो अस्तित्व आफै बाँच्नु थियो। अर्काको खेलौना या पुतली बनेर बाँच्नु थिएन। तर उसलाई बेचिदिए धनीलाई, जसले कि उसको खेलौना बनेर बाँच्यो। यो मनोविज्ञान कसरी प्रष्टिन्छ? प्रत्येक साहित्य यद्यपि मनको कमाल हो साहित्य भनेको, अरू केही पनि भन्दैन म, मनकै कमाल हो। तर त्यसले यतिसम्म पस्ट्याउँछ, यस्तोसम्म पस्ट्याउँछ कि कुनै कुनै अब अरू त छोडिदिउँ, डाङडाङ र डुङडुङ डर लाग्दो बाजा राति राति हिँड्थे गोर्खाली राजा। आजभन्दा 150-200 वर्ष अगाडि त यस्तै थिए कविता, यस्ता कविता थिए 200 वर्ष अगाडि। तर अब पछि आएर के भयो? विश्वविजेता नेपाली, गोर्खाली आदि आदि भन्दा भन्दै अब आयो भाव, वीरता भाव देखाउनु पर्दा के लेखे त? म एउटा श्लोक भन्छु हजुरहरूलाई, कस्तो लाग्छ? नेपाली नाम हाम्रो त्रिभुवन भरमा छौँ बडा वीर जाति, छाती निर्धक्क हाम्रो गति अति छरितो चढ्दछौँ माथि माथि, छप्काई शत्रुलाई छप छप खुकुरी धार हाम्रो कुडिन्न, पर्दा घमसान गर्दी पछितिर मुडा हेर हाम्रो मुडिन्न। हो मुडिन्न भन्दा भन्दै 21वटा उभिएका लाइनमा अफगानिस्तानमा अन्तिम ढलेका थिए नाला पानीका बहादुर वीर बलभद्र। तोप लाग्यो हो, यसरी लड्दै थिए जसले आफूलाई। अर्कोतिर फेरि एउटा यो भयो, अर्कोतिर हामी भूपी शेरचनले के भने? हामी वीर छौँ र पो बुद्धु छौँ, हामी बुद्धु छौँ मात्र, बुद्धु मात्र छौँ, त्यसैले त हामी के छौँ? वीर छौँ। ल भन्नु अब साहित्यले कसरी मनोविज्ञान पक्रिन्छ? त्यति मात्र होइन, बहिनीको सिउँदो देखेर सिन्दुर तर्से झैँ लाग्छ, बहिनीको सिउँदो देखेर सिन्दुर तर्से झैँ लाग्छ, झस्के झैँ लाग्छ, श्रीमतीले थालमा भात होइन व्यङ्ग्य पस्के झैँ लाग्छ। हेर्नुहोस् त, बेरोजगारको जिन्दगीको एउटा चित्र यति सिङ्गो जिन्दगी बताइदियो। सिङ्गो आर्थिक अवस्था, सामाजिक अवस्था, उसको वैयक्तिक अवस्था र उसका आकाङ्क्षा र मनोविज्ञानलाई ल्याएर कहीँ पाइदियो। 2 पङ्क्ति भूपी शेरचनको भने यसरी साहित्य र मनोविज्ञानलाई कहिल्यै पनि फरक पार्नै सकिँदैन, पार्नु हुँदैन पनि। साहित्यले के गर्छ? मात्र नभएको मनस्थिति पनि सिर्जना गरेर राम्रो बनाइदिन सहयोग गर्छ, यदि सकारात्मक दृष्टिकोणबाट हेर्ने हो भने। भन्दै मेरो पनि समय सकियो होला, कुरा धेरै छन्, तैपनि मैले समय लिएँ। जे जति भने सामान्य प्रस्तुति मात्रै हो। म धनेश्वर भट्टराई बिदा मागेँ। नमस्कार।
धेरै धेरै धन्यवाद वरिष्ठ साहित्यकार धनेश्वर सरलाई। हामीले मनको कुरालाई बाँधी नराख, गाँठो परि जाला चट्ट सुनाइदेऊ। हाम्रो मनोविज्ञानमा पनि त्यो आउँछ, कुन रूपले व्यक्त गर्ने त्यो मात्रै फरक हो। तपाईँ कवितामा, गजलमा, उपन्यासमा, तपाईँ लेखमा, रचनामा, फिल्ममा अथवा कुन रूपले प्रस्तुत गर्नुहुन्छ त्यो तपाईँमा निर्भर पर्छ। र अब हामीसँग हुनुहुन्छ श्यामजी अतिथि सेनाई सर हुनुहुन्छ, वरिष्ठ साहित्यकार। उहाँलाई ससम्मान माथि जानलाई अनुरोध गर्दै म बिदा हुन्छु।
हाम्रो यस सेसनका संयोजकज्यू, वरिष्ठ डाक्टर आदरणीय सीपी सेनाईज्यू, मेरा सहमित्र साथीहरू, डिआर पोखरेल सर, धनेश्वर भट्टराई सर र उपस्थित सहभागी मित्रहरू, म हार्दिक नमन गर्दछु यहाँहरूलाई। आज हामीलाई यस्तो सौभाग्य जुट्यो, कहाँको मास्टर, कहाँको चाहिने 2-4 हरफ लेख्ने मान्छे, यस्तो यस्तो विद्वान वरिष्ठ डाक्टर साहबहरूको एउटा भेलामा हामी प्रवेश गर्ने मौका पायौँ, हेर्ने मौका पायौँ, देख्ने मौका पायौँ, सुन्ने मौका पायौँ र मानसिक स्वास्थ्य के रहेछ त्यो कुरा बुझ्ने अवसर पायौँ। यसको लागि म आयोजक सरहरूलाई म मुरी धन्यवाद टक्राउँछु। हामीहरू अब मानसिक स्वास्थ्य यस बारेमा अब हामी त के जान्नछौँ र, खासै त्यसमा अध्ययन छैन। अध्ययन कतिसम्म छ भने प्राध्यापक डाक्टर सीपी शर्माज्यू अब यो साइकियाट्रिक फिल्डमा काम गर्ने नेपालको वरिष्ठ डाक्टर, उहाँले बेला बेलामा नारायणी टुडे र अन्य पत्रिकाहरूमा उहाँहरूको लेख आउने गरेका छ। त्यो चाहिँ भने मैले नछोडिकन पढेको छु जस्तो लाग्छ। उहाँका पुस्तकहरू पनि छन् र कतिपय उहाँका बिरामीहरू सीएमसी हस्पिटलमा गएर फर्किएपछि भेट हुन्छ उनीहरूसित, उनीहरूको कथन पनि सुनिराखेको छु। कस्तो रहेछ यो रोग, यसले के गर्ने रहेछ, डाक्टरको भूमिका के हुँदो रहेछ यसमा। अघि देखियो नि त्यहाँ धामी झाँक्रीहरू चाहिँ ऊ गरेर कति चाहिँ मनोविज्ञान चाहिँ बिग्रिराखेको, पारिवारिक कलहले गर्दा, वैवाहिक कारणले गर्दा, गरिबीको कारणले गर्दा, अनेक रोगका कारणले गर्दाखेरि मान्छेमा मानसिक रोगग्रस्त भइराखेको छ, ढ्याङ्ग्रो पिटाएको त हामीले अघि पनि अब हेऱ्यौँ देख्यौँ। यस्ता हाम्रा समाजमा धेरै छन्। तर अहिले केही 10-15-20 वर्षदेखि यता आएर बल्ल त्यो कुरो जनमानसले अलिअलि बुझ्दैछ। यो मानसिक रोग, मानसिक स्वास्थ्य एउटा रोग मध्येको राजा हो जस्तो लाग्छ मलाई। रोग मध्येको राजा, यमराज यो रोग। किनभने यदि मान्छेको मानसिक सन्तुलन नै ठिक छैन भने, स्वास्थ्य नै ठिक छैन भने, नाना थरीका सोचहरूले पालेर बस्छ भने, बाबुआमालाई पनि मुड्की हान्न थाल्छ भने, साथीभाइहरूलाई चाहिँ नि पिट्न थाल्छ, ढाँट्छ, बाटो हिँडिरहेको मान्छेलाई चाहिँ नि लौरोले हान्छ, गोली हान्छ, इभन गोली समेत हान्छ। यस्तो अवस्थामा हाम्रो समाज गुज्रिराखेको छ। हाम्रो मानव समाज पीडित भइराखेको छ। त्यो कारणले गर्दाखेरि विद्यार्थी पढ्न छोडेर चाहिँ नि भौतारिएको छ मानसिक स्वास्थ्यको कारणले गर्दाखेरि। एउटा किसान के गर्ने भनेर ना जवाब भएर चाहिँ नि मागेर खाएर हिँडिराखेका छ अवस्था छ। कति मान्छेहरू बौलाएर हिँडेका छन्, राति चाहिँदो नचाहिँदो कुराहरू फलाकेर हिँडिराखेको छन्। यो सबै अहिले आएर बुझिँदैछ। मैले पनि भर्खर बुझ्दैछु। यो चाहिँ सबै मानसिक रोगको करामत रहेछ। यसको उपचार यदि राम्रोसँग समयमा बेलामा हुन सक्यो भने यो मानव समाज पीडित हुन नपर्ने रहेछ। यो कुरो चाहिँ नि हाम्रै चितवन जिल्लामा, हाम्रै नेपालमा त्यति धेरै वर्ष भएको छैन यो कुरो मान्छेमा, यो ज्ञान मान्छेमा प्रवेश गरेको। केही समय भयो। अब चाहिँ अब मान्छेहरू अलिकता नराम्रो सपना देखेर मन भरङ्ग भयो भने, अलिकता मन चाहिँ नि चञ्चल भयो भने, अथवा चाहिँ नि कुनै कुरामा नराम्रो लत बस्यो भने, अथवा चाहिँ नि कसैलाई शत्रु साधना गर्नु छ गर्दै चाहिँ नि एउटा नकारात्मक काममा चाहिँ नि उत्रियो भने, त्यतिखेर मान्छेले भन्न थाले, उसका चाहिँ छरछिमेकीले उसको परिवारले पनि भन्न थाल्यो, तिमी धामी झाँक्रीको मात्रै चाहिँ नि भरमा नपर, सिएमसीमा चाहिँ नि डाक्टर सिपी सेडाई बस्नुहुन्छ, त्यहाँ जाऊ एकपल्ट देखाऊ। विद्यार्थी पढ्दा पढ्दै फेल भयो, आज फेल भयो, भोलि फेल भयो। दुनियाँ बाबुआमाले 50औं लाख रुपियाँ चाहिँ नि डुबाएर मेडिकल कलेजमा भर्ना गरिदिएको छ। छोराछोरी वहाँ गएर नाना थरीका चाहिँ नि सङ्गतमा फसेका छन् र चाहिँ नि पढ्नु घोक्नु, एउटा गुरुहरूलाई सम्मान अनुशासन आदर गर्नुको सट्टा नाना भाँतीको अहिलेको चाहिँ नि हावामा बगेका छन्। त्यस्ता मान्छेहरूले आफ्नो जिन्दगी बर्बाद गरेका छन्। त्यस्तालाई समेत हामी अब सल्लाह के दिन्छौँ भने साइकियाट्रिक ट्रिटमेन्ट गर्न जाऊ तिमी, अनि तिम्रो रोग ठिक हुन्छ, निको हुन्छ। यस किसिमको माहौल चाहिँ अहिले बन्दैछ। मलाई लाग्छ आयोजक डाक्टर साहबहरूले यस किसिमको आयोजना, यस किसिमको जुन एउटा सम्मेलनको आयोजना गर्नुभएको छ, यसको एउटा चाहिँ नि ठुलो उपलब्धि छ। यो कुरोलाई अति साह्रै प्रचारमा ल्याउनुपर्छ। नेपालभरि नेपालको गाउँ जिल्ला केन्द्रमा यसको चाहिँ राम्रो मिडियाको मार्फतबाट राम्रो प्रचार होस्। यो काम साइकियाट्रिक फिल्डमा साह्रै राम्रो काम भएको छ। यसले चाहिँ नि विभिन्न देशका चाहिँ नि ख्यातिप्राप्त साइकियाट्रिक डाक्टरहरू पाल्नु भएको छ, उहाँहरूको विचारहरू यहाँ व्यक्त भएको छ। यसले धेरै फाइदा चाहिँ नि हुन्छ। यसलाई सकेसम्म यो आयोजक समितिले चाहिँ नि यसलाई मिडियाको मार्फतबाट प्रचारमा ल्याओ। यसले धेरै फाइदा छ नेपालमा, धेरै फाइदा छ इन्डियामा, धेरै फाइदा छ हाम्रो एसियन मुलुकहरूमा। यो एउटा साह्रै राम्रो काम भएको छ अहिले यतिखेर। अब म जान्छु, अब भन्न त मेरा चाहिँ विद्वान मित्रहरूले भनिसक्नु भएको छ। लेखनमा, साहित्यमा, अन्य विधाहरूमा चाहिँ नि यो मानसिक स्वास्थ्यको असर कस्तो छ त? लेखकहरू, कविहरूको मानसिकता कस्तो छ? आफ्नो चाहिँ नि लेखन कार्यमा कसरी लेखिराखेका छन्? अहिलेको अवस्था के छ? मलाई लाग्छ अहिलेको अवस्थाको बारेमा यो कुराहरू चाहिँ नि आएको हुनुपर्छ अहिले। त्यसो भएको हुनाले अब मलाई के लाग्छ भने साहित्य भनेको त ऐना हो, समाज हेर्ने ऐना। समाजमा जे कुरा घटेको छ त्यो कुरो साहित्यकारले आफ्नो चाहिँ नि कलमले लेख्छ र त्यो चाहिँ नि समाजलाई नै दिन्छ। फेरि समाजका कुरा लेख्छ, समाजलाई नै दिन्छ। यो चाहिँ नि साहित्यकारको काम हो। कुनै ठाउँमा चाहिँ नि विद्यार्थी बिग्रिरहेको छ, कुनै ठाउँमा धनीले गरिबलाई शोषण गरिराखेको छ, कुनै ठाउँमा चाहिँ नि नजायज कामहरू भइराखेको छ, कुनै ठाउँमा चाहिँ नि अनुशासनहीन काम भइराखेको छ, गरिब छ, धनी छ, धेरै उत्पीडनहरू चाहिँ नि बढिरहेको छ। अब शासकले शासितलाई धेरै चाहिँ नि प्रताडना दिइरहेको छ भने त्यो चाहिँ नि कुरा लेखकले आफ्नो कलमले कापीमा उतार्छ, लेख्छ, अनि त्यो चाहिँ नि ऐनाको स्वरूप ल हेर भनेर समाजै फिर्ता दिन्छ। त्यसबाट सुध्रने मौका चाहिँ नि हुन्छ। सामाजिक कुरीतिहरूको सुध्रने मौका हुन्छ, व्यक्तिको पनि सुध्रिने मौका हुन्छ। त्यसो भएको हुनाले यो साहित्यकार कवितामा, नोभेलमा, कुनै सर्ट स्टोरीहरूमा अहिलेको समाजको गतिविधिहरू राखिएको हुन्छ र लेखकको मानसिकता पनि अब त्यतैतिर घुमिरहेको हुन्छ। लेखकको मानसिकता त्यतैतिर, आजभोलि समाज कतातिर गइरहेको छ, विद्यार्थी कता गइरहेको छ, कलेजका प्रोफेसरहरू कता गएका छन्, स्कुलका टिचरहरू कता गएको छन्, व्यापारी कता गएको छन्, 5 रुपियाँको माललाई चाहिँ नि 6 रुपियाँ 7 रुपियाँ लिनु स्वाभाविकै हो। 5 रुपियाँको माललाई चाहिँ नि 50 रुपियाँ लिएर बेचेर अनुचित फाइदा गरेर त्यो शोषण भइराखेको अवस्था त्यो चाहिँ नि साहित्यकारले देख्छ टटकारो रूपमा। त्यस्ता कुराहरूमा इङ्गित हुन्छ साहित्यकार। त्यसो भएको हुनाले अनि त्यसपछि लेखिदिन्छ र त्यो समाजमा चाहिँ नि दिन्छ। र यसरी अब म चाहिँ नि अब धेरै कुराहरू यहाँ निवेदन गर्न आवश्यक छैन। यहाँहरू बुद्धिजीवी हुनुहुन्छ, विद्वान हुनुहुन्छ, सबै कुरा बुझिराख्नु भएको छ। अहिलेको मिडिया जुन चाहिँ नि यान्त्रिक मिडियाहरू छन्, यसले चाहिँ नि दुईटै काम गरिराखेको छ। फाइदा पनि गरेको छ, बेफाइदा पनि गरेको छ। फाइदा कसरी गरेको छ भने अब चाहिँ नि नेपालमै बसेर आफ्नो घरमा कोठामा बसेर सारा विश्वको कुराहरू ज्ञान हुन्छ। विज्ञानको कुरा, अर्थशास्त्रको कुरा, राजनीतिका कुरा, स्पेसका कुराहरू, सबै कुराहरूको ज्ञान चाहिँ नि घरमै बसेर हुन्छ। त्यो फाइदा हो। कलेजको चाहिँ नि लेक्चररले पढाएको कुरा कोठामै बसेर चाहिँ सुन्न पाइन्छ, कोठामै बसेर जाँच दिन पाइन्छ, कोठामै बसेर चाहिँ रिजल्ट हेर्न पाइयो। त्यो सबै कुराहरू त्यो फाइदा हो। त्यो र बेफाइदाको कुरा पनि यो घातक भएर अहिले बढिरहेको छ। खास गरिकन म भन्छु, यहाँहरू सबैलाई अनुभव पनि छ पक्कै पनि, घरमा सानो नानीहरू यति चाहिँ नि बर्बादी अवस्थामा गइरहेका छन्। घरका परिवारहरू, टिनेजरहरू यति बिग्रेका छन्। स्कुलका विद्यार्थीहरू, कलेजका विद्यार्थीहरू, एउटा चाहिँ नि केटा होस् केटी होस्, हाइवेमा हिँडिरहेको छ। त्यो हिँड्दा हिँड्दै मैले कतिपल्ट देखेको छु। मैले ती नानीलाई, ती बाबुलाई बोलाएर भनेको पनि छु, ए बाबु अरू बेलामा हेर न, त्यो बाटो क्रस गर्न लागेको बेलामा पनि आफ्नो हातमा मोबाइल यसरी आँखा यता हाल्दै बाटो चाहिँ नि क्रस गर्नु। यस्तो चाहिँ नि भयानक कामहरू चाहिँ नि भइराखेको छ। पढ्नलाई विद्यार्थीलाई मनै छैन होइन। छोरी बुहारीहरू, छोराछोरीहरूलाई कहिले काम सिद्ध्याउला र त्यो मोबाइलमा चाहिँ नि ध्यान जाला। हेर्नुहोस् है, यस किसिमको चाहिँ नि माहौल सिर्जना भइराखेको छ। यो अति दुःखदायी कुरा हो। यसले समाजलाई चाहिँ नि धेरै नराम्रो दिशातिर चाहिँ नि मोडिँदैछ। अब साहित्यकारहरूले पनि यो विषयमा प्रवेश गर्दैछन्। यसरी चाहिँ नि नराम्रो किसिमबाट यसरी चाहिँ नि डोज दिन्छन्। हामीले दिनुपर्छ। उनीहरूलाई बचाउनु छ, विद्यार्थीलाई बचाउनु छ, घरायसी मान्छेलाई बचाउनु छ। इभन बुढाबुढीहरू पनि चाहिँ नि पल्टिएर चस्मा लगाएर अब त्यसको असर के हुन्छ ज्ञान नभइकन पल्टिएर चाहिँ मोबाइलका चाहिँ नि तस्बिरहरू हेरिरहेका हुन्छन्, चाहिँदो नचाहिँदो तस्बिरहरू। अब साहित्यकारको ध्यान चाहिँ नि त्यतातिर जान्छ। अब त्यसलाई रोक्नेपट्टि चाहिँ नि अवश्य जानुपर्छ। यसरी अब चाहिँ नि अहिलेको हाम्रो समाज अब यसरी मानसिकता, समाजको मानसिकता, व्यक्तिको मानसिकता कता चाहिँ नि ओझेलमा पर्दै गएको जस्तो भएको छ। अहिले यसरी गर्दाखेरि सबै बिरामी हुने, उद्देश्य पुरा नहुने, राम्रो काम गर्न नसक्ने, यस्तो चाहिँ नि बिरामी, साइकियाट्रिस्टको बिरामी चाहिँ नि बनाउने कामहरू यो चाहिँ नि नयाँ यो अहिले आएको चाहिँ नि मिडियाको मार्फत, यान्त्रिक चाहिँ नि उसको साधनको मार्फत एकदमै चाहिँ नि बढिराखेको अवस्था छ। यो कुरा सबै डाक्टर साहबहरूले पनि अब बुझेकै कुरा हो। मैले चाहिँ नि मैले आफ्नो हिसाबले देखेको कुराहरू अभिव्यक्त गरेँ। यी सबै कुराहरू यहाँ चाहिँ नि राख्दै अब यहाँबाट चाहिँ नि हामीले दिनु त के छ र सबैले बुझेकै कुरा हो। तर हामीलाई धेरै ठुलो खुराक भएको छ। खुराक प्राप्त भएको हुनाले यहाँका सबै डाक्टर साहबहरूप्रति आभार व्यक्त गर्दै म आफ्नो भनाइ के अरे सम्पन्न सक्नुभन्दा अगाडि मेरो परिचय चाहिँ म श्यामजी अतिथि सेडाई हो मेरो नाम। म यही भरतपुर 12 को बासिन्दा हो र मैले धेरै वर्षसम्म शिक्षा सेवामा बसेर काम गरेँ। अनि त्यसपछि म अहिले रिटायर भएर सरकारी पेन्सन खाएर बसेको छु। म त्यो सुविधा लिएर बसेको छु म। र पहिला पनि म साहित्यको विद्यार्थी हो, कलेजतिर स्कुलतिर पढ्दाखेरि। र त्यो 32 वर्ष जाहिर खाँदाखेरि मैले सिर्जना भन्ने कुरा मैले गर्नै सकिनँ। मेरो जीवनको ठुलो घाटा यो कुरा। मैले जहाँ चाहिँ भन्ने गरेको छु, लेख्ने गरेको छु, अरूलाई पनि भन्ने गरेको छु। किनभनेदेखि शिक्षाको जागिर सधैँ चाहिने राजनीति भकुन्डो खेलिरहनु पर्ने। त्यो कारणले गर्दाखेरि मैले 32 वर्षको जागिरको दौरानमा मैले केही पनि गर्न सकिनँ। 64 सालमा मैले जागिर छोडेँ यता म फेरि पूर्ववत फर्किएको छु। साहित्यमा रुचि छ, केही गरिराखेको छु, लेखिराखेको छु, पुस्तकहरू पढेको छु र विद्वानहरूको चाहिँ सङ्गत मेरो भइराखेको छ। प्राध्यापक डाक्टर साहबहरूको नजिक छु म र मेरो चाहिने 3टा निबन्धहरू चाहिने प्रकाशित छन्। अर्को पनि निबन्ध चाहिने प्रकाशित चाहिने को तयारीमा प्रेसमा गइराखेको छ। यस्तै अनुकूल पर्यो भने फेरि यहाँहरूसित यस्तै भेटघाट गर्ने। पक्कै पनि अस्पतालमा त भेट भइन्छ डाक्टर साहबहरूसित। यिनै निवेदन गर्दै म बिदा हुन्छु। नमस्कार।
धन्यवाद श्यामजी अतिथि सेनाइज्यू। उहाँबाट हामीले धेरै कुरा पायौँ। अब म अलिकति लेखन कला तपाईँ हामीले अब लेख्न सुरु गर्नुपर्छ। साहित्यमा रुचि राख्नेले साहित्यमा केही भएन भने पनि हाम्रो मोबाइलमा स्ट्याटसबाटै सुरु किन नगर्ने, अथवा अक्टोबर 10 आउँछ विश्व मानसिक स्वास्थ्य दिवस, सेप्टेम्बर 25 हुन्छ विश्व आत्महत्या रोकथाम दिवस, HIV/AIDS दिवस, यस्ता थुप्रै स्वास्थ्य सम्बन्धी दिवसहरूमा पनि हामी आफ्ना लेखहरू लेख्न सक्छौँ। दैनिकीहरूबाट सुरु गर्न सक्छौँ। अनि हाम्रा लेखहरू हाम्रो समय सापेक्ष कुनै नयाँ औषधि आयो, कुनै नयाँ रोग पत्ता लाग्यो, त्यसको बारेमा तपाईँ लेख्न सक्नुहुन्छ। स्मारिकाहरूबाट तपाईँहरू सुरु गर्न सक्नुहुन्छ। अनि तपाईँले तपाईँका नजिकका पत्र पत्रिकासँग सम्बन्धित रहेर सम्पर्क गरेर आफ्ना लेखहरू दिएर सुरु गर्न सक्नुहुन्छ। र बिस्तारै बिस्तारै हामी पनि भविष्यका डाक्टर हाम्रा श्यामजी अतिथि जस्तै, हाम्रा डाक्टरहरू जस्तै हामी पनि बन्न सक्छौँ। यदि भन्दै म के राख्छु फेरि पनि यहाँबाट बिदा लिन्छु। म पनि साहित्य वाङ्मय प्रतिष्ठान साहित्यिक वाङ्मय प्रतिष्ठानको आजीवन सदस्य र मेरा पनि केही कृतिहरू चाहिँ प्रकाशित छन्। यदि जानकारी दिँदै बिदा हुन्छु। धन्यवाद। डाक्टर सिबी सेनाईले अब अन्तिममा कन्क्लुजन गर्नुहुन्छ।
धन्यवाद। हाम्रो साहित्यकार लेखकहरू DR पोखरेल सर अहिले पनि भनिसक्नुभयो। उहाँले त्यति धेरै बुकहरू लेखिसक्नु भएको रहेछ। त्यति ठुलो चाहिँ उहाँमा यो साहित्यमा त्यति ठुलो योगदान छ। त्यस्तै डाक्टर धनेश्वर भट्टराई सर, उहाँले बडो जोसिलो एउटा उत्तेजना दिने खालको, ऊर्जा दिने खालको एउटा ऊर्जा प्रदान गर्ने खालको चाहिँ हामीलाई वक्तव्य दिनुभयो र यसको अलिक गराउनुभयो। त्यस्तै श्याम अतिथि सेनाई सर, उहाँले भन्नुभयो रिटायर भइसकेपछि चाहिँ मेरो झन् यो साहित्यमा असाध्यै बढी चाख बढ्यो, पहिलेदेखि गर्न पाएको पनि हुन्छ जस्तो भन्नुभयो। त्यस कारणले मेरो बुझाइ, मलाई केही पनि थाहा छैन यो सम्बन्धी, तर कलम यति शक्तिशाली छ, तरबारभन्दा कलम ठुलो भनेर भनिन्छ। कलमले मान्छेको मन चेन्ज गरिदिन्छ। त्यस्तै जहाँ पुग्दैनन् रवि त्यहाँ पुग्छन् कवि। त्यो सूर्य नपुग्ने ठाउँ पनि कवि पुगिरहेको हुन्छ अरे। त्यस कारणले लेखक कविको, साहित्यकारको कति ठुलो रोल छ यो समाज परिवर्तन गर्नमा। हामी यो मनोरोग विशेषज्ञ भएकोले साहित्यकार कविसँग चाहिँ हाम्रो रिलेसन छ। यसमा एउटा फ्युजन छ। साहित्यकारले राम्रो कुरा लेखिदियो भने त्यो पढ्ने मान्छे अलिअलि डिप्रेसन भएको त आफै निको हुन्छ, मनमा ऊर्जा प्रदान हुन्छ, आत्मबल बढ्छ। मैले एउटा उपन्यास पढेको थिएँ, एउटा आमा भन्ने उपन्यास, धेरै अगाडि हो, अहिले त बिर्सिसकेँ। त्यसले कति मान्छेको चाहिँ मन परिवर्तन गरेको रहेछ कि। त्यस कारणले सामाजिक, राजनीतिक र मनोवैज्ञानिक खालको चाहिँ असरहरू साहित्यले ल्याउँदो रहेछ, कविहरूले प्रदान गरिरहेछन्। त्यस कारणले मान्छेको मन जता पनि जान्छ। यो मन चाहिँ मुड इज इन्फेक्सियस भन्छ कि, राम्रो कुरा पढ्यो भने मन खुसी हुन्छ, नराम्रो कुरा केही त्यस्तो भयो भने मन दिक्क पार्ने हुन्छ। हाम्रो बेखुसी भइरहेको मनलाई पनि एउटा राम्रो खालको लेख जसले चाहिँ मनमा चाहिँ आत्मबल बढाउँछ, त्यो पढ्यो भने त्यो तनाव आफै हराउँछ। त्यसले चाहिँ एउटा साइकोलोजिकल फ्याक्टर एफेक्ट फिजियोलोजिकल चेन्जेस अन द बडी। साइकोलोजिकल कुराले चाहिँ बडीमा चाहिँ फिजियोलोजिकल चेन्जेस ल्याउने रहेछ कि, अनि न्युरोट्रान्समिटरको चेन्ज ल्याएर चाहिँ मान्छेलाई खुसी अथवा न्युरोट्रान्समिटरले ब्यालेन्स गराउनु खोज्दो रहेछ। साइन्टिफिक बेसिसमा यो छ। हजुरहरूको चाहिँ अब यो मनोविज्ञान मान्छेको मनमा ऊर्जा प्रदान गर्ने, मनलाई राम्रो ब्यालेन्स गर्ने असाध्यै ठुलो रोल छ जस्तो लाग्छ मलाई। त्यस कारणले मैले के आशा गरेको छु भने सबै कुरा लेखिसकेपछि कन्क्लुजनमा हामी लास्टमा चाहिँ कन्क्लुजन लेख्छौँ नि त, यस्तोमा चाहिँ अन्तिममा चाहिँ पोजिटिभ मेसेज जाने खालको अर्थात् मनमा चाहिँ अलिकति ऊर्जा आत्मबल बढाउने खालको ती कुरा आइदिए हुन्थ्यो जस्तो लाग्छ मलाई चाहिँ। त्यसले गर्दा पढिसकेपछि लास्टमा कन्क्लुजनमा चाहिँ मान्छेले ओहो यस्तो राम्रो पो गर्नु पर्ने रहेछ भन्ने खालकोतिर जान्छ जस्तो लाग्छ। त्यो कुरा चाहिँ हाम्रो यो साइकियाट्रीमा चाहिँ अथवा साइकोलोजीमा असाध्यै इम्पोर्टेन्ट छ जस्तो लाग्छ। कति मान्छेहरूलाई यो नबुझ्नाले अथवा अरू विभिन्न कारणले गर्दाखेरि केही समस्या पनि आइरहेको हुन्छ। त्यस कारणले यो कन्क्लुजन चाहिँ पोजिटिभै जाओस् भन्ने मैले आशा गरेको छु। हजुरहरूले पनि अरू राइटरहरूलाई, हजुर त लिडरहरू हो त्यसमा चाहिँ, अरूलाई पनि त्यसै भनिदिनु होला भन्ने मैले आशा गरेको छु। म धेरै बोल्न चाहन्न, अब हामी टाइम पनि धेरै छैन। थ्याङ्क यू।
Thank you all the panelists and the moderator for such a brainstorming session. Now, for the felicitation of our panelists and moderator, I would like to request Professor Dr. Sailendra Adhikari sir and Dr. Sunil Kumar Shah sir to come forward to present the token of love. Now, I would like to request Professor Dr. Ganesh Bhattacharya sir to kindly come forward to receive the token of love. Thank you. Similarly, I humbly request Dr. D.R. Professor to kindly come forward to receive the token of love. Thank you. I would like to request Sam Atati sir to come forward to receive the token of love. Thank you. I would also like to request the moderator of today's session, Kidra Prasad Sumiri sir, to kindly come forward to receive the token of love. Thank you. Thank you, Professor Dr. Sailendra sir and Sunil Kumar sir for the felicitation. Now, we are moving into the next session. But before moving into the next session, I would like to request the panelists and moderator for a group picture.
I think I would like to wait for a few minutes for participants. Shall I present the free paper first? So I think as Professor Sailendra says that participants are having tea break, so in the meantime maybe I'll go with the free paper. So the title of the presentation is Only Movers and Shakers Are Not Seizure. It's about a case series. Okay, before that presentation, this is Dr. Kumar Samsher Rana, whom we lost recently. He was a legendary doctor in Pokhara. So to pay him homage, I put this slide and few words for him. Okay, what I'll do is I'll briefly introduce what is neurographic art. Sorry, I'm confused. Okay. What I'll do is I'll briefly introduce about seizure and maybe just show you a few slides of classification, and then I'll discuss about the case series. We all know that seizure, its prevalence almost 1%. It not only affects the person's health, but the quality of life. And there are also evidence that it increases mortality as well. Few epilepsies are preventable, but much of the handicap that results could be prevented by appropriate clinical management. Same is the scenario in Nepal, demanding more resources, experts and services, especially for quality management. And it's not that epilepsy was not there, it was there from time immemorial. Generally perceived negatively as a lifelong, chronic, incurable, and named differently in different countries. Still, I think it's also in Nepal, is thought of as punishment for evil deeds, incarceration with evil spirit. A lot of myths and misconceptions are there. Despite that, we know there have been a lot of learned personalities, a lot of successful people who had epilepsy and had their career, a very successful career. So this is what I think we should highlight to our patient so that they will be little bit motivated and myth and misconception is lessened in them. It is very common in medical practice while evaluating a case of fainting attack or clouding of consciousness, health workers we hear would say there is no uprolling of eyes, deviation of angle of mouth, frothing from mouth, tongue bite, abnormal jerky movement of limbs, bladder and bowel incontinence, so seizure is ruled out. Are you sure we have ruled out the seizure? This is what the message I want to convey today. According to International League Against Epilepsy definition, above description only rules out generalized tonic-clonic seizures. So those who are working as an intern or emergency physician, I think they should know this. There are more variants of seizure in the classification which we tend to ignore as the above mindset thwart our assessment. We are preoccupied by the teaching we get in the medical school, whereby movers and shakers matre seizure ho bhanera हामीले बुझ्छौं. In the presentation, we will be discussing about case series of epilepsy without moves and shakes. Classification, I will not go through it. We know that there are many, many more variants than GT shares. So we have 3 case series of unusual seizures, 2 of diachrotic and 1 gelastic seizure. Diachrotic seizures are characterized by paroxysmal episodes of stereotyped crying. The majority of the reported seizures appear to be triggered in the hypothalamus and seem to be frequent in individuals with hypothalamic hamartoma. However, in rare cases, it may also occur beyond hypothalamic lesion. Such cases are reported below. Case 1 was a 3-year female child and was brought by her mother with complaint of crying, waking up from sleep at night without any apparent reason for past 2.5 months. The inappropriate crying lasted for 15 to 30 minutes, occurred most of the days with gap of 1 to 2 days a week without any associated symptoms, and the child did not recall any of the episode. There was no other significant past and family history. On physical examination, vitals were stable, CVS respiratory systems were normal, neurological examination revealed normal sensory, motor and cerebellar function and cranial nerves. EEG was advised, which showed high voltage generalized slowing to theta and delta range with sub-wave activity. But MRI turned out to be normal. So, I don't know, maybe the eye did not see what brain doesn't know. So these were the MRIs that we had. I'm sorry I couldn't put the picture of EEG here. So patient was then started on anti-epileptic serum sodium valproate, 200 milligram, 2.5 ml BD, and during follow-up 2 weeks after initiation of the medicine, mother reported no similar episode. Then she was continued on same treatment and she is doing well. Another case was a 6-year-old male child brought by his father and mother with complaint of crying, waking up from sleep at night without any apparent reason for, again, past 1.5 months. The inappropriate crying lasted for 4 to 5 minutes, 1 to 2 times a week without any associated symptom, and the child did not recall any of the episodes. So there were no moves and shakes at all. There was no other significant past history. I don't know how significant this is, but there was positive family history of GTCS in father in his childhood. That would be significant, I guess. On physical examination, vitals were normal. His respiratory and CVS were normal. Neurological examination, again normal. EEG was advised, followed by MRI brain. Generalized slowing to delta theta range with sub-wave activity again. But MRI brain showed normal brain. Again, started on anti-epileptic, and then the dose, after 2 weeks, the episodes reduced but did not subside, so we increased the dose. Then after 1 month's follow-up, there were no such episodes. Case 3 is about gelastic seizure, and gelastic seizure, as we know, are almost always the first seizure manifestation of hypothalamic hamartoma. However, in rare cases, it may also occur beyond hypothalamic lesion. Such was our case. A 12-year-old male child was brought by his mother, again laughing without any apparent reason for past 6 years. The delay in coming to our setup was because the parent did not recognize it, and to the doctors or to whomever, whatever medical professionals they went to, they were told that this is not an illness, it will just subside. The inappropriate laugh lasted for a few seconds and occurred 3 to 4 times a day without any associated symptoms, and the child did not recall again. He would laugh inappropriately, so much so that he would become cynosed at times. Because of excessive laughter, he would be cynosed. There was no other significant past history, but there was a positive family history of generalized tonic-clonic seizure in his grandfather. Again, vitals, CNS findings were normal, and neurological examination revealed normal. It was normal. So we did EEG and MRI again. EEG showed generalized slowing to theta range with subwave activity, noted more on frontal-central region. MRI brain showed pituitary region. Now this is a matter of curiosity. Then patient was started on anti-epileptic, which was oxcarbazepine. I really don't know why. And during his follow-up 2 weeks after initiation of AED, mother reported improvement. After 1 month, episodes of uncontrolled laughing subsided, and the child has started to focus on studies. So his study also improved. So gelastic seizures are said to be the hallmark manifestation of hypothalamic hamartoma, with onset usually in early infancy, and are produced by hypothalamic hamartoma itself. However, the case mentioned above showed pituitary lesion, which is quite uncommon, but there has been case reports where gelastic seizure was caused by focal cortical dysplasia. EEG findings were consistent to other studies and showed generalized slowing. Generally, gelastic seizures associated with hypothalamic hamartoma is said to not respond to anti-epileptic drugs, since in this case the patient responded to anti-epileptic drug. So maybe this was a case of gelastic seizure outside hypothalamic region. So in the end, what message I would like to give is, nowadays we doctors, we have become like a mechanics. You know, we depend so much on investigation and radiological examination that we think history taking is not important. So what I would like to say is, if you do not take history, you won't be able to solve the mystery, and all your medical knowledge will go in astray. Did it rhyme? I don't know. Eyes doesn't see, ear doesn't hear, nose doesn't smell, tongue doesn't taste, and skin doesn't feel what brain doesn't know. So as a doctor, I always tell my juniors that it's very, very easy to prescribe pills and to perform surgeries, but it's very difficult to become a doctor. I hope you understand what I mean by that. So as a doctor, we should not forget the skill of the art of examining the patient. It has no substitute. No lab, no radiological investigation can substitute that art. This I think I have already said. It is much of art, but it has become much of science now. So maybe we need to revisit our textbook. I'll end with this saying which I really like. You practice allopathy, homeopathy, naturopathy, or whatever pathy. If you do not practice empathy and sympathy, you will reach nowhere in treating your patient. These are the reference. Thank you very much.
Thank you, sir, for such an enlightening presentation. The symptoms that Sir explained just now, the patient with such symptom, they land up in emergency, and many times, and most of the time, they are admitted by pediatrics department or medicine department, and consultation for psychiatry is done. So it is very important for us to differentiate between seizure disorder or dissociative disorder. As we all know, sir is from Pokhara. When I was in Pokhara, so most of the patients, it was very common, dissociative disorder was very common, and in emergency, a lot of patients with dissociative, first of all, they go to the traditional healer in Nepal. They do not, hardly they come to the doctor first. But first of all, they go to the traditional healers. All the patients who are having those symptoms that sir just described it. So, and later on, the traditional healers, they were advising the patient to go to the doctor. So that was a surprise for me. Later on, I came to know that the traditional healers were given 500 rupees for referring the patient. I don't know it was by government or what was the policy, but anyways, it was very good. So it's very important for us to differentiate between these movers and shakers. Either they are seizure disorder or dissociative disorder. So it was a wonderful presentation. I would like to hand over the mic to Dr. Sunil Sam.
Now the floor is open for any comments, suggestions and questions. I have been practicing for almost 14 years now, and still these sort of cases, they are common, and it brings a challenge to us. Like I practice at Bharatpur Hospital, and we don't have like neuromedicine or pediatric neurologist, and the burden of these sort of cases are increasing. Maybe I don't know exactly whether the prevalence incidence has increased or health insurance policy has made them come to us. But as you have rightly pointed out, like just looking for whether there is up-rolling of eyes or not, whether there is tongue bite or not, doesn't suffice. It doesn't end our work. So a proper history, maybe account from taking information from the witness, if possible, witnessing by self somehow by audio-visual or recordings, then rolling out other issues that could be presenting so are very important. Thank you, sir.
With this, we close this session and we move to the next session. A neurographic art therapy, a new revenue in the treatment of mind disturbances by our professor, Dr. Nirmal sir.
Term, neurographic art. कसैले सुनेछ?
Only point is your Facebook posts.
Okay, it's a new thing, so that's not unusual. I presented in World Congress in SARF, Psychiatric Federation Conference, and there were none who knew about it. In this era of COVID, I think those who are single should be very careful in, so this is what I wanted in the audience, at least it must have woke you up. That was my recent attire in Maldives. I did hands-on neurographic art therapy session there also, and that was the Maldivian traditional dress. On the other side is my Guruji, who introduced me to neurographic art therapy. So I introduced myself as his guru. He's my guru and I am his guru. Unfortunately, he wanted to be here, but because of his ill health, okay, he's with us virtually. Now, what is neurography and why neurography? I think there's no clear answer to that question. Neurography, because someone who was related to neurology started it, so he thought he would go and name it neurography. So neurographic art is called the art of positive change. It also stimulates creativity and imagination. And if it can do to me, and I'm sure it can do to all of you. It is a simple way to work with the subconscious mind through drawing. It transforms the fear and chaos of our world into something more calming and peaceful. Art is always soothing, pleasant, positive. It always gives us, I don't need to elaborate on that. So this creative method, which stimulates new neural pathways by combining art and psychology, was invented by Russian psychologist, creative entrepreneur and architect Mr. Pavel Piskarev in 2014 and has grown rapidly around the world. This is the gentleman who started it from Russia in 2014. Okay, now we would straight away go to the workshop part. So Robinka and Nalisa are my helping hands. Have you distributed papers and black markers to all the participants? Is this in a hands free in a mic?
Actually, mic.
Yeah. Hey, you turn to. Hello. It is said that it relieves your day-to-day stress or stress in the workplace or stress with your spouse maybe. If you fight with your spouse and you are really angry, you can do neurographic art. And so, if you are there waiting in the airport, your plane is delayed, you just have a white paper and a black pen, you can start doing neurographic art. It's that easy. So, the first step is actually you write anything that is disturbing you today on the back of the page. It could be anything. Okay. And then you turn the paper and stick it in the place you are. Maybe in the OPD table. That's what I do. I stick it in the OPD table. And then whenever there is time, I do it. And there is an age-old saying that idle mind is what? Idle mind is what? Devil's playground. So it will never let you be idle. So what we do is you have written something in the paper? Any stress? Okay. Now we turn the paper. And when you do it in your workplace, because here it's for a short period, and neurographic art doesn't have to be finished in one sitting. Okay? You can do whatever time you have, you start, continue it whenever you have time next day. So ideally what you do is you stick it in the table, where the paper tape, you can stick it in the table and then keep it so that it doesn't move and you don't see what was written in the back. Okay? And then you start by making lines. Okay, the line has to be from end to end. That means from one margin to other margin, or same margin. It doesn't matter. Okay, but it cannot end in the middle anyway. Okay, so and it doesn't have to be how I'm doing. You can do it on your
on. Okay. So I start from here and make a. Okay. You carve the first one, you can make it straight also. Or whatever way you like. And now I'll make another line to intersect with the first line. So intersection is important. Okay. Let's make another line which will intersect with the third. Okay. And now we start identifying the intersection. Okay. These lines could be as many as you like, and you can create as many intersections as possible. Okay. Intersection is where the two lines cross each other. Okay, so identify the intersections. And start highlighting the intersections. Okay, the idea is you make, this is abstract art, so we play with the abstract ability of the viewer. Okay, Rangan, and it is said, beauty lies in the eyes of the beholder. Sorry, beholder. The idea is, you project that. The idea is you make a circle like this. Okay. You may ask me, why not like this? Okay. Why not like this? The idea is, in any art, you make the viewer or the person to flow. Okay, if you make it closed circle like this, their eye will come and stick there, they will not explore the entire art. So that's why we make it open like this. Okay, the idea here is, you start edges also is put down there, I don't need any start edges. Your idea is you are letting the viewer to imagine that there is a circle, so their eyes will flow. The artist's art, they say that the viewer's eyes should flow from up to down or to the periphery. You can choose to highlight the narrow part or the broader part, whichever. And here you can see there are two places where you can highlight. Okay? Or you can do it on those both sides also. You can see this will, the viewer will imagine this circle here, so their eyes will flow outside. If you close it like this, if you do it like this, their eyes will focus in that inner circle of it. They will not explore it. Someone now feel your face? And believe me, that my guru, he came to consult his relative to me, and he told me that there is this art, and he just demonstrated it, and in 5 minutes I started. So, a person who has never played with colors can do it in his 5th decade. Anybody can do it.
intersection are finished now. So now, how does it look to you? Cross to the Dear voters, expectations. Okay. Now you can create more art. Okay, you can also do creative. You can be also more innovative and start building. Start making sun, circle, or star, or mountains, and then again wherever there are intersections, you highlight it accordingly. Okay, and then when you are finished with highlighting the intersection, whatever boxes are formed or whatever spaces are formed, you start coloring them with different colors. And at the end of it all, what will come out, I'll show you in the slide. Look, I'll show you. Your intersection, I think what you want to सकेसम्म यो नेगेटिभ स्पेस भन्दै हैन यो व्हाइट स्पेस हो जति नेगेटिभ स्पेस कम भयो त्यति राम्रो हुन्छ ओके discarded one paper. The beauty of neurographic art or any abstract art is it can never go wrong. Okay, it can be average, it can be good, or it can be excellent. So you don't have to throw it. So, I think I've explained about the space, white paper, linear writing, anything you experience that day, any stress or whatever. Turn and stick paper on board or table and draw a line from end to end, draw second line to intersect, draw third line to intersect with other two lines, and then identify the intersections. Make circular marks to highlight the intersections. Make more lines. This is now being more innovative. Okay, you can make more lines, or you can also make shapes. Okay, it could be you can make, let's say, something like this. Okay. And then again highlight the intersections. Now you color the boxes with different colors of choice. Any color that you like. Okay. There is principle of coloring also. Okay, which you follow will make it very pleasing, harmonious to the viewer. Okay. Just what they say is yellow, blue and red, they are primary colors, and green, orange and purple, they are complementary colors. So if you use this technique and use primary and then complementary colors like shown in this picture, then the color becomes more harmonious. The picture becomes more harmonious. Okay, these were the initial neurographic art that I did. Now, how does it look to the beholder? I even do not believe that I could do this.
I know my friend. I know you.
Okay, so white is also a color. Sometimes you can leave some of the spaces without coloring and it becomes white. Okay, here what I do is when I'm in the OPD, I use water bottle to make different shapes. I use paper pad to paper like around That's excellent. Paperweight racket त्यसले गरे कहिले काहीँ घडी हुन्छ त्यो टेबल घडी त्यसले सेप बनाइदियो. Okay. अनि I've been registered as an artist in Pura Art Gallery. And to मेरो आर्ट मैले कुन चाहिँ सिलेक्ट गरेर लग्यो भन्दाखेरि मैले त्यो मेरो बोतल राखेर सेभ बनाएको थिएँ. Here I have used watercolor. In other pictures, I used highlighter, and when we use highlighter to underline or highlight the books, right? So that highlighter. It's very cheap, very easy. It's abstract, yeah, you can see that. That's me, and it's original, not duplicated. The mistake. I think let's have some interaction. Any queries, any difficulties? Okay.
आदि आउँछ तिमी पुरै आएर
Your mindset. You see, when you look at the clouds, what do you see? You see whatever your mindset is. Okay. If you are happy, you will see happy images. If you are not happy, you will not see. You will see gloomy images.
No, one class is not enough, Dr. Nirmal.
Actually, purpose is to play with the imagination of the viewer. Okay, your abstract art, isn't it? So what we are doing here is we are. If you look at this, what happens to your eyes? Where does it go? Yeah. You start imagining a circle there. Okay. अब यस्तो गरिदियो के हुन्छ? You may ask me. त्यो viewer को आँखा यहीँ केन्द्रित भएर गइदिन्छ. So they will not explore. जुन पनि आर्टको के हुन्छ भने इमेजिनेसन फ्लो आउट भित्र त्यही भएर यसलाई यस्तै गर्छ है। अनि कत्रो साइज भन्ने त्यसको कुनै छैन कि लिमिटेसन छैन। इन्टरसेक्सन हाइलाइट गर्ने द्याट वाज भेरी गुड क्वेसन एक्चुअली। त्यसको एन्सर क्लियर कट एन्सर छैन। वाइ डु यु हाइलाइट इट अर वाइ डु यु युज ब्ल्याक? किन ब्ल्याक चाहिँ मोर प्रोमिनेन्ट हुन्छ। पिन पोइन्ट मात्रै भयो भने त्यहीँ गएर अडियो यता फ्लो भयो नि, यता भित्र कन्स्ट्रिक्ट थियो। यो स्ट्रेट मात्रै भयो कि। यु मेक वान आर्क अफ द सर्कल। मैले बुझाउनलाई मात्रै है। आर्ट विच आई पुट इन द ग्यालरिज। अब यो चाहिँ नेक्स्ट लेभलको हो है। I don't think so I will touch this art. This is again abstract art by using alcohol-based ink and alcohol spray. Recently I traveled to Maldives and I saw a lot of my arts in the sky, you know. I think Ranjan remembers in our childhood, what we will be taught by the teachers are, they will say that you make, this is the mountain, this is the mountain. If you make one arc here, this is what? This is sun. Sunward. Okay. And you make a few stars or moon, and that becomes a scene, right? When we travel to Mauritius, I think you remember. बच्चाहरूले अनि यो चाहिँ यता ढल्केको उता ढल्केको बनायो भने पिटाइ खान्थ्यो नि त। बच्चाहरू जसरी त्यो ढल्केको काटिएको कस्तो बिगारेको भनेर हामीले जुन भन्थ्यौँ अथवा हामीले जे कुरालाई चाहिँ पिटाइ खाइयो त्यो त बच्चा त धेरै क्रिएटिभ रहेछ। अहिले पो रियलाइज भयो। सो whatever abstract मेरो आर्ट्सहरू जति पनि छ नि, I see it in the galaxy. So I think it comes from your unconscious mind somehow. I don't know. Evidence I cannot say for sure. But त्यो होला कि कहीँ देखेर आएर त्यो बनाएको होला। किनभने त्यस्तै आर्ट त्यस्तै खालको सेप I could see during sunset, during sunrise, or in the night, in the sea. You know, different such जुन हामीले एब्स्ट्र्याक्ट भनेर बनायो त्यस्तो खालको सिनहरू यो ब्रह्माण्डमा हुँदो रहेछ कि है। I don't know मैले के भन्नु खोजेको। अब यो these are again some creative work. अब म एउटा भिडियो देखाइदिन्छु है। Do you have time? टाइम छैन हामीसँग। This is the workshop we did in Pokhara. These are all kids of our colleagues, and they really loved it. So it doesn't let your child remain idle, and it increases creativity. I think my presentation ends here. Would you like to see?
Are we done, Dr. Nirmal?
Just a 5 minutes video.
Tomorrow.
Sound आउँदैन यो थोरै हेरौँ. So this was the exhibition we had in Pokhara, and after 5 or 6 months of being introduced to neurographic art, when I can do exhibition, I'm sure these beautiful minds can also do it. To different places, when I see, like in 5-star hotels, you see arts being displayed there. I can feel proud that mine are not less than any of them. No, this was by my guru. Okay, I'm 50-50 छ यसमा. These two were by me, these were mine. Okay, so I think I'll conclude here. Thank you very much.
Nirmal Prasad Lamisani sir, for such a fun and interactive session. The neurographic art therapy is definitely a stress buster. Now, for the felicitation of the speaker and the chairperson, I would like to request Dr. Ranjan Thapa sir to come forward to provide a token of love. I would like to request Professor Dr. Nirmal Prasad Lamisani sir to come front to receive the token of love.
Think about psychiatry, but this is the most valuable thing, right? It has been wonderful to learn it.
Thank you. I would like to request the chairperson of the session to receive the token of love. Thank you. Similarly, I would like to request the chairperson of the session, Dr. Rizun Nirola sir, to come forward to receive the token of love. Thank you. With your presence. With this, I would like to announce the ending of the scientific session of second day of the 9th National Conference of Psychiatric Association of Nepal, PANCON 2022. I hope we all expanded our wisdom of knowledge through multiple workshops, symposium, poster presentations, and not to mention the heartwarming conversation. I believe we definitely will cross the path in some phases of our life and have a hearty conversation. But till then, I, Dr. Subhash Subedi, intern doctor at Chitwan Medical College, would like to wave a goodbye and wish you all safe journey to home and to upcoming phases of life. Thank you. Announcement to make. All the picture and videos of the session will be posted on the PANCON 2022 Facebook page. And about the dinner will be served at Hotel Jungle Ground. So please enjoy the dinner. Thank you.